Okay, good morning, everybody. Good morning to the members of the ICD 11 work group and our invited subject matter experts. We have members of the public here in the room, and then on Zoom, we have committee members and members of the work group and members of the public. So welcome, everybody. We're delighted to be here today for the National Committee on Vital and Health Statistics, NCVHS ICD 11 Expert Roundtable meeting. My name is Rebecca Hines. I'm the Executive Secretary and Designated Federal Officer, DFO, for the committee and for the work group. And I'm just grateful for everybody who's made this event happen. As I like to say with this committee, it's team sport. So for whatever your contribution is, thank you, thank you. We're going to start off with the formality of roll call, starting off with the committee members. Jamie Ferguson.
Good morning, I'm Jamie Ferguson, member of the full committee, member of the subcommittee on standards, the subcommittee on privacy, confidentiality, and security, and co-chair of the ICD 11 work group. I have no conflicts today, but I will state that Kaiser Permanente provided a response to the ICD 11 RFI. And so if there's any discussion specific to that response, I'll recuse myself from that discussion.
Kathy Donald.
Kathy Donald, Alabama Department of Public Health. I'm a member of the Workgroup and member of the ICD 11 work group. I have no conflicts with the subject matter today.
Michael Hodgkins.
Good morning, I'm Michael Hodgkins. I'm a member of the full committee, the subcommittee on standards, and the subcommittee for ICD 11. And I have no conflicts.
Val Watzlaw.
Morning, I'm with the University of Pittsburgh. I am a member of the full committee, a co-chair of the Privacy, Confidentiality, and Security Subcommittee, and a member of Group on ICD 11, and I have no conflicts.
Vicki Mays.
Good morning, Vicki Mays, University of California, Los Angeles. I'm a member of the full committee, the privacy subcommittee, and a member of the ICD 11 ad hoc work group, and I have no conflicts.
And online in the work group, we have Rich Landon. Good morning, Rich. Can you unmute yourself?
Good morning, Rich Landon, member of the full committee, co-chair of the subcommittee on standards, member of the executive subcommittee. I have no conflicts.
Thank you, Rich. Wu Zhu, can you unmute yourself?
Yeah, good morning. I'm Wu Xu. I'm a member of the full committee and also the ICD 11 work group members. I have no conflict.
Thank you. And in the room, we have a committee member who's not on the work group, Tammy Banks.
Banks, member of the full committee, member of the executive committee, standard subcommittee. No conflicts.
Thank you. And I do believe we're going to also have Deb Strickland here today, also on the subcommittee on standards. Moving over to the members of the work group who are not committee members, starting with in the room. Oh, good Lord. I think I'm Susan Penton.
Morning, Susan Fenton with the University of Texas Health Science Center at Houston, a member of the ICD 11 work group, and no conflicts.
Sue Bowman.
Sue Bowman with the American Health Information Management Association, a member of the ICD 11 work group, and no conflicts.
Patrick Romano.
Patrick Romano from the University of California, Davis Health in Sacramento. I'm a member of the ICD 11 work group. Also have been a member of the Quality and Safety Topic Advisory Group, now called the Working Group, for the WHO County International Classifications. And I have no conflicts with today's agenda.
Mary Stanfill.
Good morning, Mary Stanfill. I work for a consulting company in the US. I am a member of the ICD 11 work group and I have no conflicts.
Thank you, Mary. Denise Love.
Love, independent health consultant, member of the work group.
Thank you, Denise. And moving over to online, we have Stella Onuoha Obilor. Stella, good morning. Unmute yourself, please.
Good morning, everyone. Stella Onoha Obelo. I'm the Vice President of Clinical Quality and Pop Health with Highmark Health and a member of the ICD 11 work group. I have no conflicts to today's agenda. Thank you.
Thank you, Stella. And there are 3 other members who have not logged in as of yet, and I think they're all Pacific time. So for obvious reasons, it's 5:30 a.m. Charles Hawley, Chris McIntosh, and Amy Easterfall. I did want to let you know that I need to be able to chat to everybody, Ella. I will put the agenda in the chat for all of those who are online when I'm able to do that. And I believe that's it. And just a reminder, although I'm not modeling good behavior, if you are going to be speaking at length, please go to the microphone or stand up so that everyone on Zoom and in the room can hear you. So thank you all. So it's all yours.
Everybody, thanks so much for staying here today. If we could bring up the slides on the NCVHS priorities. Next slide. So the committee has been working on considering and concerned about ICD 11 adoption and implementation in the US for a number of years. As you can see, ICD 11 was adopted by WHO in 2019, became effective for implementation in 2022. Considering in the US 3 components of adoption and implementation. For mortality reporting, this is done within the CDC, National Center for Health Statistics, essentially transcribing the cause of death in vital statistics to do the international reporting on mortality. But here today, we're not considering that. We're considering the morbidity coding use cases only. The first of which is a set of use cases of the use of morbidity coding for actually delivering healthcare, including population health, including things such as disease management programs, health equity, social and community health programs as well. We're also here needing to consider the set of use cases around the use of morbidity coding in ICD 11 for billing and payment purposes as a HIPAA code set. Next slide, please. So previously, NCVHS conducted an expert roundtable back in August 2018, which ended up generating a letter of recommendations to the Secretary of HHS with a number of specific recommendations for different research topics, things that needed to be understood in order to formulate appropriate policy for US adoption and implementation. And that letter also recommended creating a communications plan for engaging stakeholders across the country. We had a public health emergency that knocked that off the top priority list. But the committee is still very concerned about this. And so the committee followed up with a letter in September 2021 recommending that the ICD 11 adoption and implementation become a higher priority for the department. Reiterating, actually refining the list of research topics, and then also reiterating the call for a communications engagement plan. Next slide, please. So the overall focus of the committee.
Can you hold on a second?
Yes.
People on Zoom are having trouble hearing you.
Okay. Technical difficulties. Please stand by. We're going to get the black and white screen with
Hold on a second. We're getting all kinds of chats over Zoom. People can't hear Jamie. So for those of you on Zoom, we got an audio technician checking out the microphone.
And Rebecca, you sound fine, but Jamie just sounds a little garbled and it's just a little bit hard to hear.
Try this again. How does it sound now?
Sound fine. Okay, folks on Zoom, can you let us know how Jamie sounds?
Okay, I'm
Say a few
testing.
more words.
Clear.
Say a few more words.
Okay, a few more words.
Very, yes, much better.
It's
There you
better.
go.
Much better.
The answer is not to use the microphone. Okay. So the committee ultimately will make recommendations to the Secretary of the Department of HHS for the adoption and implementation of ICD-11, including both the HIPAA and non-HIPAA comprehensive set of use cases for morbidity coding. So our goal in the work group then is to support the committee by developing these recommendations. So you are here in this expert roundtable to help with that so that we can hear all the different perspectives so we can really understand what the priorities are to create all the information needed to craft the sound policy. Next slide, please. So the committee has discussed several goals for this work. One is, so obviously we are to develop advice and recommendations regarding adoption and implementation. We want to avoid a protracted and costly U.S. transition. Part of this is going to be having a shared understanding, lessons learned from previous transitions, for example, from ICD-9 to ICD-10-CM, and the differences between ICD-10 and ICD-11. What's unique about ICD-11 has to be understood comprehensively. We have to ensure that research is conducted to ensure a smooth transition for morbidity coding. And we have a specific interest in avoiding a full clinical modification. So we're here to identify the topics and messages to communicate, to foster early engagement and prepare for the transition to ICD-11. And now I think we're ready for the next set of slides. Which is about this meeting. Oh, do you want to take questions now? I think let's go on to the next set of slides. We're just, I think, a couple minutes.
No, you're right on.
Oh, okay. Well, let's go on to the meeting design and the anticipated takeaways, and then we can get into questions, I think, after that. Next slide, please. So this is the history and the upcoming events. As I mentioned earlier, the committee had its previous work resulting in this work group. So last year, the committee voted to create a work group, finalized the work group charge early this year, invited members in the spring, conducted regular ICD-11 work group meetings. We had an environmental scan of all the research that was conducted to date so that we could kind of filter and understand of the research questions that had previously been identified by the committee, which ones were fully or partially answered by the research that's been conducted around the world. And I will say that most of the research and studies both published and unpublished about ICD-11 have occurred outside the United States. So we also needed to understand what's happened in this country versus around the world and how those lessons from other countries might apply here. We finally were able to publish our request for information, which unfortunately had a fairly short turnaround time, but we did get answers back, and you'll hear more about that here this morning. So we're here today in an expert roundtable to gather a wide variety of stakeholder input from invited experts across the spectrum of the healthcare sector. After this, the committee will publish a meeting summary, and the work group then will also develop a report. And so the report hopefully will be able to involve all the work group members in really understanding the takeaways from this, insights, and create additional advice and considerations in the work group report. Next slide, please. So we're here today in the expert roundtable. Then the next phase of work, which is the meeting summary from this meeting and the work group report, will conclude phase 1 of the work group. We anticipate having a phase 2 of the work group after that, going into the next fiscal year, with a reauthorization of the ICD 11 work group. And so part of the report will figure out what's in the next phase of work. So our objectives for today are to identify the issues, the research questions, what's most critically important. What
You want the next slide?
well,
Oh, sorry.
not yet. Yeah, I think so we're oh, I see. Next slide, please. Sorry. So we're here today to identify the adoption and implementation issues, to understand what's most critically important to have information on to support those policy recommendations that I mentioned earlier. That's really the focus this morning. This afternoon, we want to obtain input on the development of a collaborative plan and how to sustain the work to make sure that we have community involvement and engagement of all the relevant stakeholders and interests. Hopefully having a community of interest for coordination going on into the future. Next slide, please. And so we have some additional objectives for today. We want to understand all the independent research efforts with the federal SMEs that we have, so that we can facilitate collaboration and coordination. We want to improve coordination of the U.S. delegation to WHO. Right now, it does appear that there, of course, there's a wide variety of activity going on, but we don't see really what the committee feels is appropriate coordination. So that's certainly an objective here. And then, as I mentioned earlier, we want to discuss developing a community of interest to sustain that coordination and keep the work going. I think now, Val, I'm going to pass it off to you to talk about the specific meeting design. Thank you. Next slide.
Thanks, Jamie. And if you have your agenda in front of you, you can follow along with me because I'm going to just, we do have the next slide. We're just going to talk about what we're going to cover today. So for the morning, we're going to have an excellent presentation by Kenwa, where he is going to be talking about really a practical strategy on how we can actually use ICD-11 without modification. So he's going to give several options on how to be able to do that. So I'm sure that will bring some great discussion and questions. And then we're going to have some new themes from Patrick that would come out of the request for information that, as Jamie had said, came out in June. And so I think we have received 19 responses to date. So those will be summarized into some categories and presented. Slide. And then we'll have the report out from our last week's group, where we had 8 different groups, I believe, and what they'll probably be focusing on today is the top 2 to 3 themes that came out of their groups, as well as any areas of divergent perspectives that they would like to share. And then we'll have new breakout groups here in the morning. And what we'd really like you to do is think about everything that you have gained and learned so far, and then be able to kind of prioritize then what are the research questions that are missing and what are most needed. So we really want to kind of scale that down to what you think are the gaps, and then what is really needed so we can move forward with the national research agenda, and to be able to do that in a timely manner. We don't want to have the length that we had before, going from 9 to 10. And then we'll have report outs and discussion. I think Vicki and Susan are going to be handling those. So that will come. And then next slide. the afternoon. Susan Fenton's going to lead us on continuity and sustainability and how we can continue this, move this forward and build a community of interest. And then to really break into that, really get into more detail, we'll have afternoon breakout groups in which we really want you to think about what organizations and agencies are needed to be here at the table with us and what particular research studies they may want to focus on. So you might want to think about the agency, think about the gaps that you brought up, and then see if they could actually be able to do some of that research. And then we want to collect that information so we can be able to support the NCVHS recommendations that will go to the secretary as we move ahead. So we'll have then report outs from those groups. We'll have, I hope, some great discussions. So please feel free. We'd like to hear all of your voices, not only here in the room, but also on Zoom and who are virtual. And then at around 3 o'clock of public comment. Okay. And then Jamie and Patrick are going to come up and recap at the end. So they're going to talk about what are those top research questions, the categories that they fall into. They'll also talk about the community of interest. How do we continue to coordinate and move forward? And then we will reissue a second RFI, because as Jamie said, you didn't have a whole lot of time with the first one. So we're hoping to reissue a second one where you'll have a full 90 days response time. Okay, next slide, please. So I think these are some likely questions that may come out from our discussions, but you certainly aren't limited to these. We're just giving you some ideas. So please make sure to bring up whatever you feel may be missing or what other additional questions you might have. Some of them deal with we need to really talk about the benefits of the U.S. Moving toward ICD-11 implementation. What are the costs of that implementation? And then we need to be thinking about the codes that are truly used and most needed in the US. And then think about all the ways that this can be managed with ICD-11. And I think Kenwa will, in his work and the research that he's been doing, will be able to give us some options around that. Some of them listed here. And then how does the code set that is covered in different scenarios, how does it vary by different use cases? So how could ICD-11 be used for Medicare payment versus clinical research studies versus CDC reporting? Because it can be used in so many different ways. Next slide. And then I think with the first bullet there, we'll actually get, as we had mentioned before, we really want to get to those most important research questions that we need to, that remain, what are the gaps that we haven't covered, and then what's needed for a full national research agenda. We also need to confirm what we need to do so the U.S. does not have to have a clinical modification with ICD-11. And then I think another thing that's extremely important are what are the benefits of adopting and implementing ICD-11, really thinking about what is the value and how we can talk about that in relation to all the different stakeholders. And that's it. If anybody has any questions, we'll be happy, Jamie and I'd be happy to answer them. Oh, no.
I was going to comment, the screens are pretty small, at least for me. Maybe I'm just old, but I mean, I can't really actually read the slides. So is it possible to circulate?
Yes, we can do that.
Excuse me, can the question be repeated because we were unable to hear? Sorry.
Yeah, the people in the room are having trouble seeing the slides because the screen in here is so small. So you're actually seeing the slides on Zoom more clearly than the people in the room.
Thank you.
No, seriously.
The other thing I've neglected to say is there will be a public comment period later this afternoon. And so members of the public, both in the room and online, will have an opportunity then, if you have any information you'd like to get on the record for the work group to consider. So I apologize for skipping that. The technology takeoff this morning was a little rough. So just wanted to let you know that.
can you leave the slot for when we do the next real group to discuss it? Can you leave those slides up so that we can make sure we're looking at it? Can half the screens be the first one and other half the screens be the second one?
They're all wired. They're all wired as one deck.
Okay, so can you at least put the first one up? I think that's really important so that we can look up and make sure we're covering everything.
Which slide do you want to have up during the breakouts?
The last
very last one.
Yeah,
Okay.
well, the one before the last one, since we can't have two.
So did you guys pick that up? The second to the last slide while we're in the breakouts.
Thank you.
Any other questions?
Okay, Kinwa.
My slides up, please. Hello, good morning, everyone. So I'm Kim Fong from National Library of Medicine. I hope you are hearing me okay. Oh, no room and online. Is it confirmed? Okay.
Yes, you can.
Okay. So what I'm presenting today is a practical strategy to use the ICD-11 for morbidity coding in the US without a clinical modification. So the work I'm presenting is a collaborative study between the National Library of Medicine and the National Center for Health Statistics. And the content I'm presenting represents the opinion and findings of the authors that are listed here and do not necessarily represent the official position of NLM or NCVHS. And actually, one of the co-authors, Olivier, is in the room, so I'm going to direct all the difficult questions to Olivier. Next slide, please. So it's official now, ICD-11 is the version of ICD that we'll be using. And according to WHO, it has been now used by at least 35 countries for causes of death, cancer registry, primary care, and reimbursement and others. Next slide, please. So just a quick recap on what's new in ICD-11. So the first thing is it's getting bigger. That is a constant feature of every update. We have about 40% more codes in ICD-11. We are talking about STEM codes here because there's some difference, in the way codes are called. So we're talking about the core STEM codes. We have about 4,000 more codes in ICD-11 compared to ICD-10. So the other things that are new are really actually very brand new. It's only in ICD-11. So the next thing that is new is called the foundation layer, which is the knowledge base from which the classifications, which are called linearizations, they are derived. Okay, so a little bit of explanation probably is needed here. So an analogy is like the foundation is this deep ocean of terms and meanings, right? And the linearization is what is above the shoreline that is considered important and common enough to get their own codes for coding. So they are called the linearization. In previous versions, only the linearizations or the classifications are exposed to the users for coding. But now we have a deep ocean of terms and meanings. And this foundation is not static. It's being updated constantly, even daily. But the versions for coding, the linearizations, they are versioned. Most probably will be released every year as a new version. So with the foundation, the capability of coding is massively increased. So we have at least 120,000 codable terms in the foundation. So another new feature in ICD-11 is post-coordination, which in ICD-11 parlance is called cluster coding. That means combining existing codes to generate new meaning. And there's a special section of ICD-11 support post-coordination, which is called extension codes. We have about 14,000 extension codes, which potentially represent millions of different combinations for new meanings in ICD-11. So you can see now from the core, which is about just over 10,000 codes, right? Moving to the foundation, you increase the capacity of coding by one whole order of magnitude. You now have 100,000. And moving to co-post-coordination further, you increase it by another order of magnitude. Now you have millions of possibilities of coding. So that's the extent of change that we are seeing in ICD 11. So WHO's version is that they are trying to build a common foundation and extension, not just for ICD 11, but for all the classification within the so-called WHOFIC community, which is the WHO's family of international classifications, which includes ICD, the new International Classification of Health Interventions, or ICH, and the International Classification on Functioning, Disability, and Health, or ICF. Next slide, please. So because of this massively increased capability of coding in ICD-11, in the first letter of NCVHS to the secretary, one of the key recommendations is that research should be done to see whether ICD-11 can fully replace ICD NCM for morbidity coding without actually building a full-fledged NCM. And that's what our research is going to address. Next slide, please. So first of all, you may ask, what are the benefits of doing away with the clinical modification? First of all, we can avoid the cost and of maintaining and creating ICD-11 CM. Secondly, without the lag time of creating a clinical modification, we can start to use this newer, more up-to-date international medical classification earlier. And the third advantage is that without a clinical modification, we can avoid the potential divergence of the clinical modification from the core international ICD classification. So theoretically, that should not happen because ICD, the clinical modification should base off the core ICD classification completely. But as time goes on, there are notable differences. I'm quoting some examples here. For example, unspecified diabetes mellitus is not found in ICD-10-CM. It's because diabetes unspecified is coded as type 2 diabetes by default in the US. So we don't need unspecified diabetes. On the other side, disorders of retroperitoneum is only found in ICD-10-CM and not in ICD-10. So you can see that potentially there can be discrepancies. And last but not least, by avoiding a clinical modification, you can use native ICD-11 together with all these new features. And one of them is the foundation, right? So the foundation, because of its structure and its size and its new design, it can help ICD, the alignment between ICD and other terminologies. And a notable example here is SNOMED-CT. And just a bit of history. So in the original design, SNOMED-CT was supposed to be used to build the foundation. But however, it was not realized for various reasons. But there's now renewed interest to align the foundation and SNOMED-CT. And actually, a pilot study has been done to map between two sets of codes. So stay tuned in this area. So another use of the foundation would be to support automated coding, which would be another big gain. Next slide, please. So we've done, before this study, we've done another study called feasibility study of looking at how feasible it is to replace ICD-10-CM with ICD-11. And in that study, it became clear to us that if we just use the linearization codes, and by the way, the principal linearization in ICD is called ICD-11 MMS, short for mortality and morbidity statistics. And this is the main code is comparable to ICD-10 classification. If we only use the codes in this linearization, it is clear to us that it's not sufficient to replace all codes in ICD-10-CM. So that's why we look at other possibilities. So we basically look at three options. The first option is to create a US linearization. That means exposing more entities in the foundation under the shoreline initially to expose them for coding. The second option we've looked at is post-coordination. And we looked at the possibility of using the existing things in ICD-11 that will support post-coordination. And we can have an option of adding our own US-specific extension codes if that's necessary. We call this option of adding codes we call it a US extension of extension. And the third option we looked at is actually adding brand new stem codes. These new stem codes will not be linked in any way to the foundation or to the MMS. But this is the last resort we consider will be necessary. And we think that is likely to be a small set that is going to be needed for the US, and we can call it, ICD-CM at 11CM Lite. Next slide, please. So in order to derive a practical strategy of replacing ICD-10CM with 11, we will rank all the options according to several criteria. The first is the level of effort that is involved in the development of maintenance of that option. The second is the ease of implementation by users. And the third is the risk of divergence of this new product from the core ICD-11. So after considering these factors, we've derived this proposed strategy, which is we'll start with the MMS mean codes, and then we'll use additional foundation codes in linearization, and then we'll post-coordinate with existing ICD-11 options, and then if necessary, we'll propose new extension codes. And the final resort will be to add new stem codes. Next slide, please. And so our design is quite simple. It's just to test this strategy in a representative sample of ICD-10CM codes. So we've come up with a decision that we will test this in two samples. The first sample is what we call the horizontal sample. This will include the most commonly used codes from all chapters of ICD-10CM, in the US. This is similar to cutting off the top layer of the cake, right? This is the most commonly used codes. And in addition to that, we add a vertical sample, which is all codes from a single chapter. And this is similar to cutting a slice of a cake and look at the whole slice. And this is what we call the vertical sample. And the two approaches will complement each other because the vertical sample will give information that probably is not contained in the horizontal sample and vice versa. Next slide, please. So to get the commonly used ICD-10CM codes, we first based on the Medicare claims. So the Medicare database is the biggest, one of the biggest collections of ICD-10CM codes in use in the US. And the identified claims data is available to use to researchers through this platform of CMS called the Virtual Research Data Center. But one problem with using the Medicare data is that most Medicare beneficiaries, they are kind of elderly. So we'll be missing codes in some chapters of ICD-10CM. So this includes pregnancy codes, new perinatal codes, and also congenital malformation codes. So in order to correct that, we have acquired an alternative source of ICD-10CM codes for these three chapters. And these are from the University of Nebraska Medical Center. So we have to say thanks to James Campbell and also Alan Burns for giving us data. So altogether in this horizontal sample, we have 909 codes, which will cover at least 60% of usage in each chapter of ICD-10CM. And we're excluding the digestive disease from codes from this sample because it's covered in the next sample. Next slide, please. So we've chosen the chapter 11, which is diseases of digestive systems, as the vertical sample. This is because in our previous study, we found that in this chapter, there's good spread of the usage of the codes that is not too concentrated in too few codes. And in our previous study, we found that the coverage of digestive diseases in ICD-11 is about medium. It's not too high or too low. And also, this chapter has about 800 codes, which is manageable for manual review and coding. Next slide, please. So what we did is we have two terminologies who are very experienced and knowledgeable in both ICD-10CM and ICD-11. They will code these two samples in ICD in this waterfall manner. So we start with an ICD-10CM code, we look for an exact matching ICD-11 stem code, and then if we do not have an exact match, we'll go to the foundation to try to identify an exact match. Failing that, we'll go to the next step, we'll try post-coordination. And then eventually, if that fails, we'll try to create a new stem code. Next slide, please. So for the coding exercise, we use the online ICD 11 browser. We did not use the MMS browser, which is blue in color, but we have to use the maintenance browser, which is orange color, which is the orange browser, because all the foundation entities are shown more completely in this maintenance browser compared to the blue browser. So one thing I have to explain here is among the foundation terms, most of them are included as inclusion or index terms under the main code. Not all of them are identified or considered as separate entities. So not all of them are codable. So if you look at, it's more to see, if you can see, you can look at the diagram here. The screenshot on the left shows what it is when you try to search for an entity, for example, seborrheic keratosis, right? And under this condition, there are 5 index terms that I've shown in this diagram. And the first 3 do not have anything additional after the term. So if you look at the last 2 examples, if you look carefully, there are small double arrows at the end of it. So those arrows are clickable. When you click on those arrows, you'll open up a new page. So when you click on the acanthotic seborrheic keratosis arrow, you will see the smaller diagram on the right, which shows that there's a new page, which is just for the seborrheic acanthotic seborrheic keratosis. What this means is, among the 5 index terms, the first 3 are considered to be synonymous with the main term. That means there's nowhere else to go. So that is the page for that index term. But for the last 2, they're considered as distinct entities from the main code. So if you click on them, you land up in another page, which means that this is another entity. So the way that they identify a separate entity in foundation is that they use the URIs, right? Your universal resource identifiers. So the URIs are shown in the browser at the top. So I've shown here that seborrheic keratosis has a URI, and the smaller diagram, acanthotic seborrheic keratosis, has another URI, and they're different URIs. So that's the way that you can tell that the foundation is referring, the foundation entity is different from the main code. Okay, that's how we record the foundation that we use. Next slide, please. So in the use of post-coordination, we're not restricting to the options that are shown on the browser. This is because the browser options, they're reflecting sanction rules that are primarily for preventing redundancy arising from creating a post-coordination expression that is synonymous with an existing STEM code. So it doesn't reflect all the possible or meaningful combinations for post-coordination. So in our exercise, we'll allow combinations of post-coordination codes if they are clinically meaningful. So just give an example here. So the code for tinnitus in ICD-11 is MC41. If you look it up on the browser, there's no option to post-coordinate this code with, for example, left, right, or bilateral, which is clinically meaningful. So we would say that if under that situation, we'll allow the addition of the laterality qualifier to this main code if it's meaningful, if it's clinically meaningful. So for post-coordination, we allow the use of stem codes and extension codes as stipulated in the ICD coding guideline. We will also allow foundation entities as well, because we expect that to be exposed in the US linearization and will be available for post-coordination. And as I have mentioned earlier, if it's necessary, we propose new extension codes. Next slide, please. So one special situation we have to deal with is when we allow the use of multiple stem codes for one ICD-10 CM codes. So that is allowed in post-coordination according to coding guidelines. But we've also found another situation whereby the use of multiple stem codes is warranted. So we allow that if that results in exact match. And all these exceptional cases, kind of exceptional, they are broad to narrow matches. So I've shown one example here. So the ICD-10 CM code for volvulus is K52 6.2. In ICD 11, volvulus is coded separately if it involves the small intestine or the large intestine. So there are two different codes for volvulus in ICD 11. So we allow the two codes in combination to represent that ICD-10 CM code. But this is, strictly speaking, is not post-coordination because the logical interpretation is different. In this case, the two volvulus codes, they represent a combination by the OR operator. That means either one of the condition is true. But in post-coordination, the interpretation is always N. For example, in this case here, ulcer of esophagus with bleeding will be coded with a post-coordinated code of esophageal ulcer and esophageal hemorrhage. So that is the difference here that we have to be aware of. So we allow this combination of codes in special situations, and the interpretation is that they are all joined by all. Next slide, please. So this is the main slide summarizing all the results, and I'll go in detail in each of the categories. So the rows, different rows, show the result of different steps of the waterfall mapping, and the columns show that which sample is coming from. Next slide, please. So first, if you look at the STEM code level, both the frequently used codes and the digestive disease codes, they have about 30-something% of coverage. That means about a third of the codes we can find an exact match in as a STEM code. This next slide, please. So if we move to the foundation level, we can see that for digestive disease, it's bumped up by about 16% if you use the foundation level. But on the frequently used codes side, the increase is more modest. It's about 6%. So if you think about it, it makes sense because the so-called vertical sample contain more codes that are less frequently used, and the less frequently used codes will be, by that analogy, will be something more likely to be underwater. It will not be promoted to the level of linearization because they're less commonly used and less important. So if you expose more of the foundation, actually the impact will be more on the less frequently used codes than the commonly used codes, right? That makes sense? So the bump in coverage for the digestive disease is higher than for the commonly used codes. Next slide, please. So this is just one example of that case when exposure of foundation will give us an exact match. So in ICD-10, the code is K43.1, incisional hernia with gangrene. This is not a very common condition. So in ICD-11, we only have the STEM code incisional hernia. And one of the index terms is incisional hernia with gangrene, and that has not been promoted to the linearization. But it has its distinct URI, so we can expose that foundation entity for coding. Next slide, please. So next we'll go to post-coordination. So this is just about post-coordination using existing abilities of post-coordination in ICD-11. So you can see that post-coordination is really a game changer. So overall, the post-coordination give about 40% bump in coverage of the combined set of codes. The effect is more seen in the frequently used codes than in the digestive disease codes. And the reason, because in the so-called horizontal sample, the bump is over 50%. But for the vertical sample, the bump is about 30%. And there's actually a reason for that. The next slide, please. So this is because the impact of post-coordination, actually the coding performance is very variable across different chapters. Particularly for post-coordination, you can see that the biggest contribution for post-coordination is on this chapter 19, which is for the injury poison codes. Almost all of the codes in this chapter will require an episode of care indicator. So that is only available for in post-coordination. So that's why with post-coordination, there's over 300 codes in this chapter that becomes fully represented. So because of this outsized impact of this chapter being benefited by post-coordination, we have that over 50% bump in the overall population of the most frequently used codes. The other chapters that also benefit significantly are the pregnancy chapter. Of course, the pregnancy codes, most of them have trimester information. And also for cases for disease like of the eye or musculoskeletal system, they will benefit from the laterality modification as well. Next slide, please. So if you go to the next step, that means we have to propose new extension codes. The gain is moderate, like about the same, about 70% for both the vertical and horizontal sample. So next slide, please. So here are some of the examples of the new standing extension codes that we'll need. For the digestive diseases, the most commonly missing extension codes are the severity scale values. For example, the different classes of loss of teeth. And for the frequent use codes, the most commonly missing extension codes is the anatomy and topography, like a fifth metatarsal bone. And following that will be the health devices like urinary catheters, and also temporality, like the first trimester of pregnancy. Next slide, please. So the next we'll go to the final step, which is the new stem codes. So from our study, it seems that there are really not a lot of codes that will need a brand new stem codes. And in our sample, combined sample, we have only about 61 codes that will need a brand new stem code in ICD-11 to represent. Next slide, please. So some examples. I would say by just eyeballing this list, you'll see that why we need a new stem code is because sometimes the ICD-10 code is kind of a fuzzy clinical meaning. For example, pregnancy with inconclusive fetal viability, altered mental status, or enteroptosis. So these are more fuzzy clinical entities. So they're not represented in ICD-11. And the others are things like related more to administrative needs, like do not resuscitate or encounter for therapeutic drug level monitoring. And this last example, the long-term bracket current use of anticoagulants is interesting. So I'll discuss it more in detail in the next slide. Next slide, please. So we found a bunch of codes that have a similar pattern. And in the case of needing to create a new stem code, sometimes post-coagulation can help to reduce the number of new stem codes that we need. So the examples I've given here is long-term use of anticoagulants, long-term use of insulin, and long-term use of aspirin. So in ICD-11, there's no code that corresponds to this meaning. But by casual look, you may think that the code personal history of long-term use of anticoagulants will be a suitable match, but actually it is not. Because it's lumping the two meanings, the meaning of two codes in ICD-10-CM. In ICD-10-CM, if the patient has a long-term use of a certain medication and is continuing to use that, it is coded as Z79 something, right? If the patient has the personal history of the medical treatment but has stopped that treatment, it's coded in a different way. It's coded as Z92. So these two meanings are lumped in the ICD-11 code. We cannot use that ICD-11 code to represent one of the meanings. So we definitely will need a new stem code, but with that new stem code, let's say long-term bracket current use of medication, we can combine that with the extension codes in ICD-11. Like there's extension code for anticoagulant, there's extension code for insulin, there's extension code for aspirin. So we don't need three stem codes, new stem codes to represent the three ICD-10 codes. Next slide, please. So taking this further, how post-coagulation can help us achieve parsimony of codes. If we allow, but ICD, WHO allows the use of post-coagulation across Hufig classifications, which is their vision because they want to use it in unison. They want to use the classifications in unison. So that can also cut down in the number of extension codes of new STEM codes that we need. Example I have here is vagostomy complications and other complications of gastric band procedure. In this case, we can use the existing ICD-11 STEM code, which is gastrointestinal, abdominal, or abdominal wall procedure associated with injury or harm in therapeutic use, unspecified approach. We can use this STEM code and combine it with ICHI codes. ICHI codes, remember, is the International Classification for Health Interventions. And they have specific codes for vagostomy and also gastric band procedure. So if we are allowed to combine codes from different PUFIC classifications, we can further cut down on the number of STEM codes or new codes that we need. Next slide, please. So I'm going to change gear here a little bit because since we're looking at the replacement of one coding system with another, so one consideration is cardinality. So it's nice if we always have one-to-one correspondence between the two systems, but it can be problematic if we do not have that situation. So we've done a separate analysis on cases that are not one-to-one matches. So the first group of codes we look at is one ICD-10 STEM code to multiple ICD-11 codes. We found 26 codes like that, and most of them are the broad to narrow codes that I referred to earlier. And this should not be a big problem for backward compatibility with ICD-10 because we are primarily coding in ICD-11, so the two codes will roll up to the same ICD-10 codes. So it should not create any problem. But the other case of the many-to-one map, like many ICD-10 codes mapping to the same ICD-11 codes will be problematic. So we found 59 codes like that, and we've done detailed analysis of that too. So next slide, please. So among the many-to-one matches, we can identify three kinds of codes. So the first one is residual categories, like the unspecified and other codes that map to the same ICD-11 codes. So these are tricky because it's difficult to map exactly the residual categories. And the second category we found is some codes that might not be distinguishable, at least in our mapping methodology in ICD-10. For example, Crohn's disease unspecified without complications and Crohn's disease unspecified with unspecified complications. In our mapping methodology, we ignore the part that signifies absence of information. That's why these two codes map to the same code of Crohn's disease in ICD-11. So whether this will cause a big problem, we need further investigation. We have to look at whether these two codes, particularly the one with unspecified complication, is actually used significantly in ICD because, it might not be used at all. And the third situation we found, many-to-one matches, is the questionable synonymy in ICD-11. So one example is obstructive sleep apnea and sleep apnea. They're coded differently in ICD-10 because they mean different things. But in ICD-11, under obstructive sleep apnea, there's an index term sleep apnea NOS, which means that, they're considered synonymous. So these cases, I think the WHO needs to review whether they actually mean that they are synonymous or not. Next slide, please. So I'm coming to the final part of my presentation here. So one thing to stress is that our findings probably represent the best case scenario of replacing ICD-10 with ICD-11. So there are several prerequisites that we need to have before we can achieve these results. The first one is we definitely need post-coordination. Without it, we'll drastically cut the coverage. And of course, they will still have impact on coding, tooling, education, and coding variability. And considerations need to be given to the compatibility with other messaging standards and other standards, such as FHIR or NCPDP. Next slide, please. So because post-coordination is such a centerpiece in our study, I'm going to talk a little bit more about post-coordination. So in post-coordination, we can envisage it to be implemented in different ways. So if we have two axes here, the one is expressivity, and the y-axis is the effort to implement. Usually with more expressivity, the effort to implement is higher. So at the most basic level, which I'll call the enumerated approach to post coordination, we'll enumerate all the code combinations identified. In a way, we can argue that ICD-10-CM already uses post coordination because there is formulaic expansion of some of the codes, like pregnancy will routinely add the trimester information. Just that we're not calling it post coordination IC11 because we give them unique codes. So we raise their status to the first class citizens like the other codes. That's why we're not saying that we use post coordination ICD-10-CM, but the essence is that it's something like post coordination. So at this level, we'll enumerate out the possibilities, and we can do different things with them, right? We can give them codes, we can give them identifiers. And the second level here is what the ICD-11 is doing. So they're crafting sanction rules which allow different combinations for specific codes, right? That is what's happening on the coding tool. And the next level is what I'll call the logic-based post-coordination implementation, which is something like Snowman. So they define a concept model, logical concept model, that will guide what combinations are acceptable. And since we're in the days of AI, I think the next level, which is still very hypothetical, we can use AI instead of handcrafting the list or the models or the sanction rules. We can learn all the different allowable combinations by looking at massive raw volumes of clinical data. And we don't even have to know what rules we use. But that's something for the future. But going back to the task at hand, right? We are trying to replace ICD-10-CM with ICD-11. And we want to do post coordination. I think one possible solution is if we list all the combinations that we can use, which is finite because the list of ICD-10-CM codes that need post coordination is finite. We can list them and give them specific codes or even URIs, right? In that way, you need minimal modification of existing systems to use post coordination in ICD-11. That's just one possibility, of course. And when resources allow, of course, we want to move to the next level, which is more expressive in order to glean the full advantage of ICD-11 post-coordination. Okay, there are other prerequisites. There are two others. One is that the residual categories, as I mentioned earlier, they're tricky. They should be made compatible. And then the third prerequisite is that coding guidelines of the two systems should be harmonized. Coding guidelines are things like inclusions, exclusions, and index, and they define the boundaries of code. So in our previous study, we found that 10% of the code matches have problems with incompatibility with coding guidelines. And the most severe coding guideline conflicts can render code unmappable. Just 1 minute. So this example is from a sample, fecal impaction in ICD-10-CM. And it is, on a casual glance, it matches perfectly with the fecal impaction, which is an inclusion code in under constipation, right? But look carefully. Fecal impaction in ICD-10-CM is classified under intestinal obstruction. And there's next slide, please. I'm too excited. The next one, please. So this is a fecal infection example. And the top part is ICD-10-CM. You can see that it's under intestinal obstruction and there's an explicit exclusion of constipation. But look at ICD-11, right? It's classified right under constipation. So the two systems are not compatible. You can use one or the other. Next slide, please. So just quick limitation of our study, a sample codes are representative for all diseases and settings. Our coding was done by two terminologies and they're not externally validated. And judgment of coordination sometimes can be subjective. Next slide, please. So the conclusion of our study is that using the US linearization and using post-coordination, the existing content of ICD-10 can be represented in ICD-11 to up to almost 90%. The remainder will need new extension codes and stem codes. And because of this, we think that we should carefully consider these options before we embark on building a fully fledged ICD-11 scheme. Next slide, please. I think this. Okay, thank you very much. Sorry, I take up more time than. So.
Very good. Well, we're going to organize the discussion and Q&A by location. So starting on Zoom for our members and invited SMEs, please raise your hand if you would like to make a comment or ask a question thus far, and then we'll move to the room. Okay, so Rich Landon.
Dr. Fung, if we can go back to slide 5, please. Great presentation, by the way. This is just fantastic. The depth you've gone to and the thinking that you've put into this, it's really impressive. Under the 4th bullet, the first sub-bullet, am I correct in saying that the second instance of ICD-10, should that be ICD-11? So theoretically, ICD-10-CM should be totally compatible with ICD-11?
No, this is looking back at what happens when we build clinical modification. So starting from ICD-9-CM, the US has always built a clinical modification, and it's supposed to build off the codes in the national core version. So this is comparing the ICD-10-CM codes, how they can become incompatible with the core ICD-10.
Okay,
does that answer the question?
Yeah.
Anyone else on Zoom? I don't see any hands up, so let's go to the room.
Can you hear me? So I guess I think this is a fantastic piece of work. I think in terms of demonstrating the feasibility of mapping ICD-10-CM to ICD-11, I think we want to be careful about a couple of implications that could be drawn from this that I think are incorrect. One of them is the perfection of ICD-10-CM. Like, so if we're just going to create a system that exactly replicates ICD-10-CM, why do it? And ICD-11 was a product of over 10 years of work of international experts, including many people from the United States, who eliminated codes that weren't necessary, who expanded codes that are necessary, who really made sure that the ICD-11 was consistent with the 3 decades of knowledge that have accumulated since ICD-10 was approved. So, you know, like this question about sleep, the sleep code is not there. Well, the ICD-10, the ICD-11 codes are based on the 3rd edition of the International Classification of Sleep Disorders, which is made by the American Academy of Sleep Medicine, and they didn't have that code in their system. So it's they who reviewed this evidence, who made this recommendation that it not be coded in 2 places. So I think that level of analysis would be really important to build into this. Like if a mapping doesn't exist, do you need it? And is the mapping not there because there's evidence that it shouldn't be there? And then the other thing is, the other assumption that I want you to be really clear about is this idea that the U.S. doesn't have anything to do with the ICD-11, which is not true. The U.S. is a member state of WHO. The U.S. is actively involved in many of these committees that are part of the ICD-11. So if you were to find that there was code that wasn't in the ICD-11 that was necessary, that was needed, or a post-coordination option that was needed in the ICD-11, what you should do is propose that it be added to the ICD-11. And so, and then that would be subject to an approval process reviewed by the Medical Scientific Advisory Committee. The scientific issue, Chris chairs that committee. I'm on it. So there, and you know, the U.S. that has a long history of being very active in the WHO Family of International Classifications Network. So this would also be an opportunity to improve the ICD-11 in ways that would make it better suited to the needs of the United States, and I think everybody would be interested.
Online, we have Laura Sessions from AHRQ. Laura, you're muted. Can you unmute your phone? There you go.
Sorry.
I cannot hear you. There you go.
Muted. Can you hear me now?
Yeah, can you speak a little louder?
Sorry, I'm on high. Hope that's better.
Yes.
My question is about using the coding data from the University of Nebraska for the codes that are not captured in Medicare claims, and for those maternal as well as childhood issues. And I'm wondering about the validity of using one single medical center in one single part of the country, given the known variation in coding across geographies and actually in different centers. So I'd appreciate thoughts about that. Thank you.
Thank you, Laura. And we've had a request from the public to introduce yourself before you ask your question or make your comment.
Okay, so I'm going to answer that.
I'm Laura Sessom, the Chief Physician at AHRQ, which is the Agency for Healthcare Research and Quality. Sorry for not doing that earlier.
Thanks, Laura.
Can I answer the question now? Okay, so yes, it's a fair comment on the validity of using data from a single hospital. We acknowledge that it's one of our limitations, but the contribution from the 3 chapters is, compared to the other chapters, is in terms of number of codes, is not very high. So I think there should be like some a small defect in our design, but probably not a big one. And that the data we got from is a general hospital with all sorts of medical specialties. So we hope that will be kind of in a way representative to the codes that we were looking at. And I also want to make a response to the earlier comment, and that I think there's a very good point that we should not stop at just the compatibility with ICD-10-CM. An analogy I like to use is like we decide to upgrade our Windows, iOS, whatever. So there are always 2 considerations. The first one is backward compatibility. So will the things that I do with the old system, will they continue to work or not? But the backward compatibility alone is not enough, not motivation enough for us to move to a new system, right? The new system has to have advantages, has benefits that we're going to use it. So what our study addresses is the backward compatibility part. Of course, we're not going to stop there, and just proving that it will work as well as 10-CM is not going to make people jump up and say, oh, we want ICD-11, right? So I think that's the point I want to make.
Linda Kloss. Open your line and introduce yourself, please.
Thank you. This is Linda Kloss, a former member of the committee, and I was involved in the 2019 earlier ICD work. Could someone please discuss the World Health Organization concept that ICD-11 becomes a more consistent code set so that in the future we are not, it's an evolving version, not a rip and replace version, because I think that concept of evolution from 11 forward is very key to a lot of the discussion that we'll have today, including this issue of how we redesign the implications of this for ongoing maintenance. Thank you.
I'm qualified.
I don't know, Jamie.
I think we'll have to answer that in the discussions. I don't think we have to.
Jeff Linzer, Emory University, Atlanta, was chair of the pediatric topic advisory group for the ICD-10 RSG. A comment and questions for you. I think that when we're looking at the issue backwards, forward looking, there was a lot of issues with different languages and how words in English would translate and be utilized in other countries, which sort of has some restriction on how WHO go ahead and classify. And there was a significant issue about post-coordination and the concerns about post-coordination becoming an extreme burden on the clinician because not everybody's going to have electronic health records. My question is for you, one which was already raised. You had, if I understood the slide correctly, only 909 codes from the University of Nebraska looking at the OB, and genital conditions. And why didn't you use Medicaid data, since Medicaid would have more broadly covered those areas?
So we have Medicare data, not Medicaid, Medicare claim data.
Right. I asked why not use Medicaid data to capture those three chapters?
It's just I think Medicaid will have coverage of or I mean, it's still a special population, right?
Right. It covers OB, it covers newborn care, general. So I think you missed an opportunity to really get more information using Medicaid data or HCUP. The other thing is, one of the issues you talked about was coding I-11 itchy, which makes it sound like you would have 10 CN coded with 10 PCS, which are completely different systems.
Yes, to answer that, I think it's the vision of WHO that the three classifications within PUFIC, they can be used properly. And I'm just throwing out something that is, it's not that WHO is sanctioned this kind of vaccination, but I see an opportunity of how the three systems can work together more seamlessly.
And again, the clinicians will push back on that issue, because the understanding of where 10 PCS is versus 10 CM, and moving forward with this understanding that the clinician was going to have to use 10 PCS was part of the pushback. And I think if they start thinking that you're going to be doing multiple chapters, it's going to be much more difficult to sell. And then the last question is, are you proposing that ITCHY would replace PCS?
So, okay, so just a quick response is that anything that is complex, as complex as phosphorylation or a coding system, wouldn't be additional to clinicians. I don't think we should burden further with a new coding system, new ways of generating codes. I think that's a non-starter. So I think all this should happen in the system at the back end and make it easiest use as possible for the clinicians to do the work. So ideally, you should not even have to think about coding. They just do documentation, and the coding should be done in the back end. I think that should be the goal.
And the only way that's going to happen is if you get the electronic health record companies with their diagnosis calculators to come into the real world, as opposed to the issues that already exist in cost.
So of course there are many obstacles, but there are more implementation issues to me.
Vicky had her hand up, I think.
I'm gonna pass.
Okay.
Part of my question was answered, and I have to think for the next part.
Okay, I think it's Reverend Jimmy and then Sue.
Yes, so thank you. This is Jimmy Chang, I'm a physician, cardiologist at Duke University. I'm going to pick up on this conversation with a kind of a practical expression of what this conversation or direction this conversation is going from a clinician's perspective, and I'd like to hear your response. So first, Kim, terrific work, wonderful work. It does very nicely chart a pathway forward. My question is about how do you take that work and then make it useful to clinicians? And let me explain where I am going, at least my mental model is about this. The clinician mental model is that they live in a pre-coordinated world. They don't live in a post-coordinated world. They don't understand the concept of post-coordination. And to open that up as the way forward, to ask clinicians to bring together diagnoses, to be expressive of a context where their mental model is, this is the end. I've got an ulcerative colitis patient with complications. To ask them to do it twice is difficult. So my question really is, have you thought about how to take what you're expressing, which is post-coordination, and express it in a pre-coordinated world, a pre-coordinated way for the clinician community or the EHR vendors to actually create that so that the clinician mental model doesn't have to change to accommodate these?
To answer that, Jamie, actually, I have a slide on different ways that you can implement post-coordination. In a way, we're already using post-coordination in ICD 10CM. When the physician picks a code of, for example, small for date first trimester, it is actually, mentally can be conceived as like a diagnosis post-coordinated with the trimester, right? Just that they don't have to do it because ICD 10CM give that a specific code, raise that to the level of like a first-class citizen. So that can be one solution that we say, okay, so since there are only a limited number of post-coordinated expressions that we need to use, why don't we just do something in the back end, give them specific codes, identifiers, so the clinicians will not have to do on the fly post-coordinated. That is the danger. If they have to pick from two clicks to get the full code, that is a non-starter to me. But if they can say, okay, this is a full term, it represents the meaning, click that, and they don't need to know back end is actually a combination of codes. They give them that single. I think that's it.
I think in the room we have Sue and then Patrick.
Sue Bowman from the American Health Management Association. I was just going to follow up on your.
Can you stand up, Sue? Your voices.
I can just follow up on your point on one of your slides about post coordination. Sometimes the clinical acceptability of some of the combinations is subjective. I actually serve on the WHOFIC morbidity reference group that looks at morbidity use cases for all countries. And we've actually been working on a cancer coding exercise where there was a great deal of inconsistency resulting from the post-coordination mainly and some other issues. And so this area of inconsistency is being improved all the time. And we're actually working on what were the reasons for that? How can we fix what we call the reference guide in ICD-11, which is sort of the guidelines for use and for acceptable combinations, maybe even fix some of the extension codes or even the STEM codes to ensure there's not strange combinations of things that you can put together or multiple ways that you can code the same thing. So we are working on improving that sort of thing all the time.
Thank you. Patrick?
Patrick Romano from UC Davis. So there is, perhaps you could comment, Sue may also have thought about this a lot more, but there is a concept of post-coordination in ICD-10-CM, which relates to all of the code also and code first notes. So whenever one condition is attributed to another condition, there's usually a code first note to put the underlying cause first. Often with pregnancy codes, for example, you would code also from another chapter to indicate specific manifestations of the pregnancy complication. So this concept is already certainly quite familiar to the coding community. The problem from the data user perspective is that with this type of post-coordination, we don't really know when things go together. In other words, we get these 25 codes in a bucket, but we don't really know which two have been post-coordinated using the code first or code also logic. So could you comment on that issue?
So in my slide about post-coordination, the gradation, if you need to tackle the code also problem, you cannot list all the possible combinations. So you need to go to the next level, which is you have sanction rules, like what the ICD-11 coding tool is doing. Like you have this code and possible combinations, you open up another list that the user can pick. This is probably the only way to implement post-coordination in that sense of combination of conditions. But in a more elementary level, like trimester pregnancy, episode of care, I think you can list all the possible combinations and do it in a simpler way that will not require a whole lot of change in the related system.
Thank you. I see two more questions in the room and then we're going to go to a break. I'll start with Mary.
Hello, Mary Stanfield. I'm the official representative to WHO for the Reference and Morbidity Committee, as well as the EIC Committee from the International Federation of Health Information Management. So I don't represent WHO in this comment, but my understanding is, and I want to go back to Linda Claus's question, which was about, is there are we going to continue this yanking bull and completely replace? It is my understanding from my work with the committees at WHO that WHO's intent is to no longer do that the ICD-11 would continue to be maintained, refreshed, revised, and not get to that place where it has to be completely replaced. So, we're hearing comments like there will be no ICD-12. So whether or not that indeed becomes the path, and again, I'm not speaking for WHO, so there's confirmation, but that is my understanding in the work that I've done with them. So I think that gets to Linda Claus's original question. I also want to comment on just a quick couple other things because we've got a lot of comments here. To the question about using Medicaid data, it's difficult to get Medicaid data. It's very easy to get Medicare Med-Part data. It's easily available. AHRQ's HCUP, however, is a very good data source and maybe might be another one to look at. Your comment, Jimmy, about the doctors and the way doctors think, not necessarily, they reported versus post-coordinated. We actually have that problem with IC10CM today, right? Because anytime you think of, in IC10CM, all the codes are pre-coordinated. We have a ton of combination codes, which in fact is a defined post-coordinated code. So, and we find that they don't use the combination. They code diabetes, uncomplicated, and peripheral vascular disease, and the separate. So whether the code set is pre-coordinated or post-coordinated, the issue is more of an informatics issue, a user issue. How do they go about selecting? So I guess I would just admit that we have the same problem today that we have to solve, whether we stay with IC10CM or we figure out how to use IC11. And I think the issue at hand is post-coordination is both an opportunity and a huge challenge, right? How are we going to? And it does present a really great opportunity potentially to capture information, some fabulous information, especially if you look at patient safety and quality issues. So definitely something we're going to be discussing. The other one comment I would make about it's the intervention classification so what WHO is, they have a foundation, and WHO in the foundation, WHO is harmonizing everything. So ICD is in there, ICHE is in there, ICF is in there. But in the linearization and today's work group, our work group, in fact, charge is specific to ICD-11 MMS. The use for, not MMS, but the use for morbidity reporting. So not procedures. We're not talking about PCS or replacing that or co-mingling procedures and diagnoses per se. That isn't even come up. We're focusing on the use of ICD for morbidity. And that is my experience indeed also with WHO, that they are when they pull from the foundation specific to in the linearization specific to one another. So hopefully maybe that context helps.
Thank you very much. We're going to go to the last question in the room, then we have the last question online after that.
Okay. Hello, I'm Bruce Cuthbert from the National Institute of Mental Health. I have a question. I really appreciate all the information and your thoughtful plan. I have a question about the curating of all of these things. I can hear that there are a lot of specific medical areas that can decide upon these things, but otherwise we do have a lot of other sources. For instance, you mentioned SNOMED, that's another source. You mentioned the Universal Research Identifier. So there are a lot of areas that have to decide, let alone all the groups of the WHO who have to make a decision if they make a change. Also, you mentioned on slide 3 that with foundations, there are frequent daily updates. So I'm just wondering, in terms of our recommendations to the HHS, is that an issue for us to talk about? How do we work with all of these various curating bodies working together and reaching decisions?
Let's just get one more question online. Dr. Amy Sukapati, invited expert today. Your line's open, Amy.
Hi, good morning. Good to be with all of you. So my comment is related to the specificity at the one code level. And I think thinking through this, not just the post coordination, but again, in EMRs where we're often using a specific code to drive real-time decision support, order sets, health maintenance. There are feeding registries that drive outreach. When we do this work, it's not if you have this two combination of code, make this thing fire. It's if you have this one code, make it fire. So today in those circumstances, as was mentioned before, where there's obstetric or other codes that are a series that are driving a clinical term, we actually disaggregate that series and have to choose the one code. So there are use cases where the specificity of what we're trying to have clinically meaningful is really important real time for the work that's being done in the EMR. And as we think through that, better defining those use cases where before a post coordination maneuver would drive, a change, but rather a one code specificity. I think those are the use cases that are really important to think about. And that's the promise that we're hoping probably to find as one part of ICD 11.
Response to those last two questions.
Thank you. I think the first question is about how we feedback and coordinate with WHO. I think that would probably agenda in the afternoon agenda, right? How to move forward, like how can we continuity, probably hopefully a central coordinating body that we communicate with the WHO, right? I think that answer. And code specificity, I think in our study, at the single code level, we have a modest amount of direct exact matches. So if we do not allow the use of post-coordination or the foundation, I think the specificity is the required specificity is more difficult to get.
Thank you. Thank you very much. Thank you for all the questions and discussion. We're now running about 10 minutes behind schedule. So instead of a 15-minute break, we're now going to go to a 10-minute break. And we'll come back at 20 past the hour. Thank you.
So again, I'm Patrick Romano, member of the ICD 11 Workgroup from the University of California, Davis Health. And I'm going to be summarizing the results of the request for information, which was published in the Federal Register on June 13th of this year. We received 19 responses, and I've summarized those responses with the help of a couple of members of my research team at UC Davis and Sue Bowman, who's here today and will correct all of my mistakes. Next slide. So these were the 12 questions that were announced in the Federal Register. And again, I later these you'll see that I have highlighted in the following slides responses to most of these questions, but I have sort of regrouped things a little bit in this streamlining the presentation. Next slide. So the first question was about the perceived benefits of implementing ICD-11 morbidity in your setting or organization. And what I will say at the outset is that we received a number of responses to the effect that we don't see any benefits. What are the benefits? Show us the benefits. So there is a fair amount, I think, of skepticism about whether there are benefits. And this may come to some extent as a result of the experience with NCM, where perhaps the community was oversold about benefits of implementation. And lo and behold, it was a lot of work, and benefits haven't really been realized. But I will say that a fair number of commenters also recognized that the increased alignment, integration with EHR systems, richer clinical terminology, vocabulary standards, the ability to link better with STOMED CT terminology, the ability to describe health conditions in greater detail, that these kinds of features would really support a better research, better clinical decision-making, more accurate payment, more accurate assessment of risk-adjusted quality, which is my field, better clinical decision-making, and addressing equity. This transition is likely to be, in some ways, more difficult than the transition to ICD-10 for the reasons already discussed this morning. But it's also likely to be more impactful because of this ability to post-coordinate, to really express detail, to introduce more flexibility, more clinical precision, to more accurately capture the clinical stories of what's happening to our patients. And of course, as we've discussed, ICD-11 provides flexibility and structure to capture new discoveries, really streamlining future expansions. Next slide. So the second question was about what type of information or research your organization will need to inform assessment of ICD-11. And I apologize for the small print here, but obviously people have a lot of questions. People have a lot of unknowns. And this is, of course, the challenges we begin this discussion. So the first top of the list for almost everybody is the question that Benoit has addressed, which is, do we need U.S. clinical modification? And if not, how will U.S.-specific coding needs be addressed? What kind of linearization within the WHO Foundation framework would be implemented? We really need to understand the structural and content differences between our current code set and where we're going. And of course, then we need to understand what kind of mapping tools, mapping software would be available to support this US linearization. Obviously, people want details. People want to know what's the timeline, the milestones, the achievement benchmarks, what are the governance processes, how do we have input into new codes, modified codes, how can we really assess the costs and benefits, how can we integrate the changes with ICD, with other code sets that are used across the healthcare system, and how do we deal with all the software changes, with all the staffing and staff training requirements, and all the various use cases. So people want to see case studies showing that it can be done, what's the cost, so forth. So a lot of information needs. Next slide. Considerations with respect to some of the major use cases in the US. So basically, there's a lot of interest in how do we simplify, how do we streamline the coding process, really to perhaps automate coding, perhaps to use natural language processing more effectively, allowing users to add combinations of STEM and extension codes that would evolve over the course of the patient's illness, and really allow us to guide clinical decision-making, guide payment in ways that aren't currently possible. We do have a lot of infrastructure that has to be considered. Mandated X12 transactions and the specification of those transactions is not my area of expertise, but clearly there are a lot of other considerations that have to be integrated and considered. There are existing mandates at both state and national levels related to content standards, interoperability, so forth. So all of these factors must be considered. We have to think through all of the various use cases related to payment systems, public health, social service entities, population health, and research. Each of those use cases has its own software systems, its own tools, its own ways of utilizing ICD-10-CM. And so a lot of thought has to be put into how those systems get upgraded and modernized to accommodate ICD-11. Next slide. There are unique U.S. coding and terminology considerations that we asked about, particularly a lot of interest in social drivers of health. Kinwa mentioned a couple of those examples, but particularly on the health plan side and the provider side, there's a lot of interest in incorporating social drivers that may affect healthcare utilization. Concepts such as loneliness, lack of social support, digital literacy, internet access, intimate partner violence, so forth. Certain types of providers expressed concern that the current ICD-11 codes aren't sufficient for their needs in the U.S. healthcare system. There are obviously a lot of other regulatory standards that have to be considered. Again, the mandated X12 transactions we discussed, that whole framework will need to be updated to accommodate ICD-11. And then, of course, more generally, we have to decide if the U.S. has unique ICD coding requirements that WHO is unwilling or unable to accommodate within the foundation of ICD-11. How do we accommodate that in the U.S.? First, we need a governance model to coordinate all of this from the U.S. perspective. Next slide. We asked about how HHS should implement ICD-11 in the U.S. for morbidity coding. Again, there's an underlying assumption, if you will, that we can't stay with ICD-10-CM forever. So at some point, we will have to move along with the rest of the world to ICD-11. So how do we do that? And I think the general sense was we should do so slowly and carefully. And there are various ideas about the time frame. Some thought we could do it as quickly as 2 years. I think on the outside, we were looking at 10 years, which probably is more realistic. Clearly, a lot of concern about really implementing it only after the return on investment is demonstrated. Having a detailed roadmap and a transition plan, a phased approach with benchmarks along the way. Coordination across all agencies, particularly the federal agencies, but also with private stakeholder groups. Really, deep collaboration is required with all the stakeholders in the healthcare industry to ensure that we have tailored implementation guidance and materials. A lot of interest in crosswalks, or what we prefer to call mappings, with different code sets. A number of folks commented on drawing the lessons from ICD-10-CM, but there's some difference of opinion about what those lessons are. Right? So some people at the one extreme say the lesson is don't do it, ever. Some people say, well, what worked in ICD-10 was a hard cut, that we had one date, October 1st, 2015, when the whole healthcare system switched. Other people said, no, we learned that didn't work. We need a transition period during which users can use both code sets. And the system can accommodate both code sets. People can get gradually used to ICD-11. So this is a point of some disagreement. There was some expressed view that we should basically facilitate access to all the underlying concepts of the foundation. We've already discussed that a bit. And really, the linearization, particular features of the linearization, I think are important. Kim has discussed that a little bit. Chris Tompkins' group has also done some work in this domain that he may share with us a little bit later. Next slide. We asked about the role of specific federal entities, and the commenters expressed differing views on this question. So some advocate what we might call a traditional American approach, which is to rely on the National Center for Health Statistics to serve that coordinating role with cooperating parties, the equivalent of an ICD-10-CM Coordination Maintenance Committee, which would now be ICD-11 with the U.S. linearization. Some advocated really a stronger or central role for NLM, really leveraging its role as the National Release Center for STOMED CT, but with input from others. And then some advocate an enhanced role for CMS, because of course CMS is the primary regulator and user of coded data within the federal government. Finally, some suggested creating some kind of a national steering committee or task force that would exist outside the government. It would include representation from both public and private stakeholders. So this will be a topic, I think, for the discussion this afternoon. Next slide. We asked about what kinds of resources stakeholders would require. We've already discussed this to some extent, but people are really looking for useful resources, a lot of educational resources, of course, technological resources, browsers, coding tools, automated tools as much as possible. And very important to consider the special needs of physician practices, rural hospitals, Medicaid providers, small health plans, so forth, that aren't well equipped to undertake a major transition. Next slide. Other operational impacts, upheaval was a term we heard in several comments. Huge costs, significant costs, really considering other legislative and regulatory requirements that are going on at the same time. And again, lessons learned and considering the implications. Obviously, each stakeholder who wrote a letter said, well, don't forget about us. So that's understandable, of course. Pharmacists are concerned about the implications for pharmacy, clinical laboratories, physician practices, rural hospitals. So this is a multi-trillion-dollar industry in which millions of people are affected and lots of different perspectives. Testing. So a huge requirement really for testing, and people want to be able to learn from others' experience in testing, implement their own testing according to standard processes. Next, final slide. So a few concluding thoughts. I think the RFI really launched robust discussion among key stakeholders, engaged people, and helped set the agenda for today. Thank you to those of you both here and online who contributed to that discussion. We recognize the number and detail provided in the comments was limited by the timeline. I think there were 17 days for response. The general tenor of responses suggests some cautious enthusiasm, if you will, some understanding of the benefits of ICD-11, but a need for careful attention to many critical challenges. Learning from ICD-10 experience, more planning, more research, more testing, more evaluation are needed before we set a launch date. And I think it's fair to say that another RFI cycle may be launched after this meeting to allow further feedback from those who were unable to participate in June. So that's it for me. Thank you very much.
And now we're going to get the feedback from
So I just wanted for context, because this is a FACO work group, they have been meeting, and last week they had a preliminary conversation. So for members of the public, what you're about to hear is their pre-work from preliminary conversations to help get us a head start this morning. So each person who's going to present now is a member of the ICD-11 work group or a SME to the work group. So please just introduce yourself because the bios are still not posted on the website just yet. So
sure. My name is Chris Tompkins from Brandeis University. I've been on the faculty there for quite a long time. I'm health economics, health payment expert, totally into the ICD-11 world in about last year or so. I'm representing Group 8 of the breakout session from last week. So if we can, the first slide that pertains to, those of you who are familiar with the breakout slides will notice, especially it's kind of funny to say, who's missing, what's missing? This is the reverse order. This is what came to me in the airport and on the airplane coming over here. If I'm going to tell a story, actually, I'm going to reverse the order of the slides. And before I went to the airport, actually, I had my annual physical. And my primary care doc was also an informaticist. And so I was saying, right after here, I'm going to the airport. And I thought I'd tease and say, I'm going to the airport to go to Washington to talk about how we're going to bring ICD 11 to you. I was expecting, oh no, what do you mean? He said, it's about time. He said, 10 years ago, when we were, looking ahead shortly to 10, people said, ICD 11 is ready. They're already working on it. It's going to be much better. Why don't we skip 10 and go to 11? But now on the first slide that I'm presenting here, the first thought here is, and it was mentioned earlier, I think by Mary, that no, there's no skip 11. Let's go to 12. There's no 12. The WHO said, and we all should probably applaud this, let's not do this way anymore. We have this, somebody called it rip and replace. Why don't we have a centralized process where we can actually manage the changes over time, bring in new concepts from genetics and so forth, integrate them into the system, and just keep this going as a global community, really. And so the second point from the work group is that, and we've heard it through the comments Patrick was telling, a lot of things are already going on. People think like, oh no, ICD-11 is just one more thing. But some of these other things might integrate and gel nicely with ICD-11, including we called out the idea of AI. AI is really coming into the forefront in many ways. And if it gets integrated into the, how do you code this? What's the sophisticated way to code this? How do you, maybe reduce some of the human labor and some of the burden that's associated with this and turn this into a truly automated exercise where the minds can really just be to review what's already been done, for example, through AI. Echoing the third bullet there is that we need an education plan. I said right at the beginning, I've been doing this for about a year, pulled into the ICD-11. And I go to my colleagues and they say, ICD-11? You've been the first person who's ever said it to me. Why are you talking about it? Nobody else is. And I think I hit the nadir when a longstanding surgeon colleague of mine who's heavily in policy and spends a lot of time in Washington, would be presented to some of our work to him. And he said, this is great. I can see how this is going to fit. It's going boom, 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 boom. This is really going to work. And the only trouble is, if I go into a meeting and say, let's talk about ICD-11, I'm going to be shot on sight. So can we get an education campaign going so that in my circles and in many other circles, you're not just always the first person and you're sounding like you're talking some foreign language? Can we start this process of saying, yes, we're moving here. This is what it entails. Not all the details are settled, but let's start really talking about it. The regulatory process, I've seen both sides of this, the rulemaking process, the dreaded rulemaking process, which seems to take so long. Can we maybe have some statutory authority to make some of this sub-regulation so we don't have to do this big cycle for things? Or secondly, in June 2019, CMS said that they're working on a project for expedited regulation process. Can I'm not calling on anybody right now, but can we be updated on that project to see whether the rulemaking process could be substituted to some extent? And lastly, we thought, yes, this is a public good and we're imposing costs on people. So can we have an implementation plan that also distributes funds, particularly where it's most necessary, to help people in rural and small areas and so forth, to really facilitate the process, and maybe also to get some platforms, subsidizing some platforms so the industry sectors and components can work together on a problem, come up with a unified answer, plug it into the rest of it. So it's not just an all scattered shot. Next slide, please.
Can you wrap up in about 2? Can you wrap up in 2 to 3 minutes?
Okay.
Thanks.
Okay, so we're talking about resistance. One of the key themes is not all resistance is equal. Some people really embrace the idea, they get it, they want it, but they're thinking, oh no, I can't afford it. I don't have the staffing and the resources and the training. And even if we did, we don't have the staffing and the training to really exploit it. So can we plan this in such a way that we have the resources to really get the benefits from it? The types of resistance, this is a very profitable industry. And the first thing, as soon as you say this has changed, people are saying, who's going to win? Who's going to lose? How much am I going to lose? Am I going to lose? Am I going to resist anything unless I know I'm going to win? Third bullet is, not everybody wants better information. nobody wants to look bad. And nobody wants better information that could make them look bad. And my world is in risk-bearing arrangements, payment models. The way to beat risk-bearing and payment models is to have bad information so that you can actually be getting by with something that makes your work harder than it really is. And this system is facing hundreds of millions, if not billions of dollars a year in losses because we don't have the information to really guide those processes. Next slide. What is needed to ensure that we don't need to see it? Can we decide what is good enough? What is the target? Because if we decided the target is it to mimic CM and then we maybe go from there? Or do we just want a complete set of clinical concepts that everybody can agree to? And then we'll use pre-coordination and post-coordination and just do it. And as soon as we have a model to do it, whether it's Kim Laws or the one that I'm working on, which I think is compatible, I think we can just do this and choose a logical model that everybody can say, yes, this will get us to the target, narrow it down, test it, and then really go through some pre-implementation phases with some beta testing. Last slide, please. The research questions. This has to be stepwise, but it should be worked conjunction in as a program. Number one, somebody has to show how to do it. In one of these glorious EHR systems we're reading about, can we actually show how you're finding the data elements, you're pulling them in, you're coding them properly, and get an implementation guide out there. And then show how the information can be aggregated and made available, who's responsible, what happens next. And then the third bullet, can we simulate some use cases to say, if you had really rich information, this is how well you could do. But if you were living in the current world of CM and balkanized EHRs and all the rest, this is where you're really missing, and this is why it's not happening. And really make the case empirically by way of logic and simulation to really show that there's more to this and there's more to be gotten. And it's costing us not to move to I-11. So lastly, the last bullet is to say, can we turn this into an organized program of research? If the lights come out of this meeting and everybody goes their separate ways and we're going to have at least pockets of work over here, it's not really going to be coordinated. Can we have a coordinating center, a program of research that says, you're the best ones to do this, you're the best ones to do this. They have to connect at this point and sign me up for the 2-year time frame. All for help.
Good morning. Those folks on Zoom, can you hear me?
Yes.
Yes. Great. Okay. Well, good morning, everyone. My name is Leslie Prowitz. I work for the American Medical Association, as evidenced by the purple on my jacket. I'm also in my role there. I'm the director for CPT content management and development. I'm also a certified ICD-10 and CPT code. But I'm here today to talk about the results from our Workgroup 7, and definitely want to give kudos to Valerie for her excellent mediation of all of our discussions and our themes and our readouts. We'll go to the next slide. And we kept this really as a stream of consciousness from what the group experienced. And a couple of things in terms of what we noted were the most important research questions remaining. What we discovered in our group was that when it comes to ICD-10 or ICD-11, the theme I would probably encapsulate it as is show me the ROI. And that's not necessarily just among physician groups, but among many constituents across the healthcare system. There are a lot of benefits that were touted, but we now live in a world where ICD-10 has been here. We have all had an experience with ICD-10, and in some cases, it may not quite have lived up to all of the expectations. So now, with a new change with any group, it's really going to be, what did we get from ICD-10? And we may have an opportunity to be more specific to those stakeholder groups, outlining what were the benefits that we really got, what was the result, what's the cost, what's the ROI, and then understanding what the broader business problem is that we're trying to solve with ICD-11. That could be a range of responses. It could just be because ICD-10 is no longer going to be supported. We have to move. But given the current state, it might be very beneficial to all of us to be able to put a finer point on the answer to that question. We also talked about needing to understand a little bit and describe the history. What are the benefits from ICD 9 to ICD 10? Part of that question is still outstanding. And it will behoove us to go through and make sure that we are able to answer that question in order to gain additional buy-in and coordination as we move forward. We need to address those outstanding questions. Part of that, and I have to applaud the work that Kim has done on the research of ICD-10 versus 11. Excellent starter research, I think, for this question in terms of understanding not only the overlay between the two code sets, but we actually went a step farther, is to say, you can look at the overlap of code sets, but have we answered the question that we have fully utilized the ICD-10 CM codes that we currently have? So it's one thing to have them in the set, but our question was, how much of the ICD-10 CM set is truly a CM modification? How much have we truly utilized those codes? Because you can put in 2,000 new codes and you really only use about 50. So the question is, and are those actually represented in ICD-11 to get a finer handle on what are the gaps that we really need to fill, particularly if there is to be a charge to move away from a CM modification. We owe it to ourselves to really understand the utilization of CM and definitely to look at it across multiple patient sets. Medicare is great, but as was outlined, there are many instances in maternity pediatrics populations that are not highly represented in Medicare data. This may be the time for us to really look at a comprehensive utilization set. That would mean looking at claims data. That may mean looking both against CMS as well as large payers, because you don't want to look at just the codes. You need to be at a comprehensive utilization view across the country.
Sorry, can you summarize two minutes?
Sure, no problem. Okay, let's go to the next slide. So in terms of what's needed to ensure the U.S. doesn't need clinical modification, many of these are what we talked about. Let's put a finer point on that actual utilization of the current set. Are we getting everything out of it that we thought we would, and really identifying what the gaps are in terms of ICD-11? Next slide. In terms of stakeholders likely to resist this, it was very difficult for us to outline one particular set. So we listed, there were a number of different ones, but I think the key theme here is making sure that we've got consistent input we've heard and we've incorporated all the way down the chain, even starting at making sure that our transaction set, the 5010 set right now, cannot accommodate ICD-11. So you really have to start there, and then make sure that we've got input from those who are initially using and entering the information. So that's the physicians, our practices, our hospitals, healthcare systems, all the way through to those who create quality programs, where there has to be reporting on these later on, and then also for research. So needing to make sure that all of these systems are aligned all the way down the set. In terms of last slide, in terms of what we saw that was missing, I think some of this is already reiterated in other slides, but really what can be extrapolated from conversions from I-10 to 11. So what can we use there? And then the issues of it being digital, governance questions, timing, workflows, and training, and to note that it is nearly impossible to under-communicate on this one, is the third thing we have. So that's our summary. Great takeaway. Sure.
Sorry, standing here. Is that right? Hi, I'm Jim Semino. I'm director of the Informatics Institute, University of Alabama, Birmingham. An internist and clinical informatician. I used to be on this committee. Not known for speaking quietly. So anyway, let me just jump in because I know we're limited time. And I think we're already hearing some common themes. So let me try to point out the things that maybe I didn't hear as much about. So in terms of remaining research questions, clearly lots, and we've talked about coverage, looking at gaps, and this is something that has to be done through formal research, not something where you just wait for feedback, people complaining, I'm missing this thing, but instead you do prospective study to say, let's assume that this thing works what would it look like, and then see what's actually happening. Do the coding rules work? Can they be applied consistently? So on. This post coordination, lots of questions about how that's going to work. Getting to implementation. So the experience with post coordination, studying that is going to, and studying it in multiple locations is going to be a challenge. And the workflows involved in trying to apply post coordination. Impact of updates. So this is actually a favorite topic of mine. Terminology updates sometimes have changes that are not recognized. The impacts, for instance, when you add a code to a terminology that has a non-elsewhere classified, you change the meaning of that code, even though it looks like exactly the same code. And so how are things like that going to be dealt with? Redundant expressions, semantic drifts, terminology is changing over time, and they need to change. They need to correct things that are wrong. They need to add new concepts like COVID, but we need to do it in a way that doesn't break what was already there, especially if we think this is an ongoing version that should, by definition, be backward compatible with itself going forward in perpetuity. Moving to automation, we can develop methods for training, but we also need to think about the cost of training. This is not something you do once and say, good, we're done. It's going to be an ongoing thing, like terminology management and maintenance itself. There are hidden costs, and we have to budget for those. We want to get to coding in the background. Right? We want the coding to happen automatically. The clinicians, patients, everybody, they think out loud, computer hears it, and they do the coding. But we need to have human verification and validation to make sure that what's getting coded is correct, and not just yep, check, but actually having people invest in that. And then making sure that we articulate the high level purpose of using ICD-11, so we don't forget why we're doing this. Okay, are we doing this to directly improve care? Are we doing this for clinical decision support? Or are we doing this for billing? Are we, of course, World Health Organization reporting? So we need to decide what is it we're really doing this for, and make sure it's supporting those things, and not have people shooting arrows at it saying, hey, it doesn't work for this, like it wasn't supposed to do that. Next slide, please. So what we're doing to make sure we don't need a CM, I think Kim has done a lot of the groundwork. We need to do more of that. Okay, so we really need to extend that. We need to look and see how do we create extension code. So in effect, there is a CM. There will be a CM. The CM will be ICD-11 plus whatever we add on. And really, ICD-10 CM is kind of ICD-10 plus things. It's just that we're not adding new levels in the hierarchy. We're adding other things that are going to be taken together, are going to be what we use in the U.S. And then we have to test the rules that we use in the U.S. You hear about linearization. Meaning that under the hood, ICD-11 is a multi-hierarchy. Okay, the linearization is computers don't deal well with that. And when you're trying to put something in one bin and you see multiple hierarchies, it's a little confusing. And so the linearization is turning it into stripping out some of those multiple hierarchical links and making sure we're happy with that. Kim showed some examples of things that were classified as a patient on anticoagulation and a patient with a history of anticoagulation. And there were two entirely different places in the hierarchy based on the coding. So, we have to be looking at those kinds of things. So I added a couple, and they created some controversy with the group when I added them. But I didn't get to say them during the meeting, so I'm saying them now. Tolerance for text extensions. When somebody's doing post coordination and they can't add what they want to say, they should be allowed to put in free text. We should record that. We should capture that. Maybe it'll be useless, but maybe it'll be better than useless, so that when somebody comes back later and says, hey, we now have a way to post coordinate that. We now can recode the data. There's a chance that we can say, this is not elsewhere classified, and this is why it's not elsewhere classified. And then we can tell, maybe we can do something with that. And we need to look at, and I say tolerance for redundant expressions, and that created all kinds of furor, because there should not be any redundant expressions within a version of ICD-11 with extensions. It should not happen. I guarantee. Chris isn't here. He's going to hear me say this, and he's going to hate me for it. I love Chris, and I've known him for 50 years, literally. And he's done great things with ICD-11. It's going to have problems. It's always, they've always had problems. So we've got to be able to handle those. But more importantly, as it evolves, there's going to be redundant ways over time. So you'll see something in 2025 or 2026 that's coded one way. The same meaning will be coded a different way in 2027 because of a version change. And there's a new pre-coordination that gets rid of the previous one, or they deprecated a pre-coordination. So now you have to use post-coordination. Whatever that is, over time, there's going to be differences, and people have to be able to handle that when they're using the data. I think we want to use data collected over time, right? That's the whole point of this for the last 120 years, is that we want to be able to compare data over time. So we have to be able to compare the redundant expressions across versions. Let's see, just quickly register. Okay, so who are the stakeholders that will resist? The usual, suspects, but we also have physicians. So what's that? But physicians also sometimes. Oh, sorry. Yeah. Next slide. Yeah. Physicians also will see value when they find that they can do a better job of capturing what's going on with their patients. The caregivers, though, they're going to need something simple. Okay. They need to be able to have all the post coordinations pre-coordinated for them. Right, so they can use what they're used to saying. When I say coordinated, I mean pre-assembled little combinations that they can go, yeah, that's what I want to say. There are people that fear that this is going to make claims rejection harder or more common, and it's going to be harder to get claims accepted. And so we need automated tools to help them get through this process. And then, of course, all the stakeholder organizations. And then lots of benefits. I think I'll this time skip past that. What's missing, I'd like to weigh in the importance of making the point that this is a classification system and a terminology. ICD-11 is a classification system and a terminology. It's meant to capture things at a clinically useful level, the way SNOMED, LOINC, RxNorm, the way it's not just forbidding things into categories like ICD-10, ICD-9, all back to ICD-0, whatever the person was. And then look at the consumer side. So we got to look at what are the implications for how is this going to improve patients' lives? How many lives? We can do one of these Carl Sagan calculations. If we do this, it's going to make this much better. How many lives will be saved by that? We have to look at the consumer experience, see if it's enhanced. Will it better capture clinical information, and will we make it easier for patients to understand their record? So when they see I have an infection, not elsewhere classified, they go, oh, so I should take antibiotic, not elsewhere classified. Now they'll hopefully see something that's at a clinical level that's going to be meaningful to them. And of course, we'll be, consumer level translations of these things. That's it.
Thank you.
Okay, I'm going to try to make up time. Rebecca's going to love me. So those joining us, you get the idea. We've had these 8 groups. We all broke out, addressed the same question. I am Mary Stanfill, who is part of this group that included Jamie Ferguson, Maddie Hugh, Tammy Love, Afton Gunsmore, and Jim Case. So I'm going to tell you what we all talked about. You're not going to hear my opinion right now. And go to the next slide, please, so that everybody can start reading it. I'm not going to read it to you. I'm just going to call out a couple of things I haven't heard yet. So evidence of benefits. We've all talked about benefits. We know we have to understand the relative advantage of moving by C11, but we need evidence. We live in an evidence-based world. So this time we need evidence. We can't just say it'll be better. Case studies. In respect to the case studies, Afton works with data, and she was saying we need to not only look at case studies we need to include input, uses, the output, the exchange, both from us and test it from interoperability and exchange, both semantically and syntactically. Mapping, not just mapping between the IC10 CM and IC11, but between not just administrative term classification, but also clinical terminologies, the myriad of them that are out there. And then a study in automation, which needs a whole lot more exploration. Next slide. So what do we need to do to not have a CM? Content evaluation, of course. Some great work has been started on that, but we do need to look at specific use cases. There are a number of technical issues that we talked about. And Jim talked about the concern about expression equivalence. And it gets to this whole post-coordination issue and the understanding how we would possibly do that. But then in addition, one thing that hasn't been mentioned by the other groups, I think yet, is this, the resource dynamics. If we're counting on WHO for maintenance issues, what does that look like? What does that mean? And study. Next slide, please. So from a stakeholder perspective, one part of the question here is not who the stakeholders are, but what's the compelling benefit? And the compelling benefits are different depending on the stakeholder group. So there's EHR vendors, for example, the large system vendors, their compelling benefit is very different. Providers, of course, need to understand what's in it for them. We have to demonstrate some sort of benefit, some sort of and somehow address that burden that they have right now. And then payers, what is the compelling benefit to evolving paying model? The issue we were talking about was this recognized misalignment between the cost and benefit. Those who bear the majority of the cost don't necessarily get the majority of the benefit, and that's a problem. Next slide. I can tell you we ran out of time, so we had a couple more comments because we could have talked for hours and hours and hours. So just a couple of things. Yes, we do need another RFI with a longer time comment period. What we need to consider, and I think it was mentioned over here earlier in the day here, that we need to think about what ICD-11 could do beyond just what ICD-10 can do. There are uses of a classification that weren't even envisioned when ICD-10 was built. So what is it we need from a classification now? What can it do? I think that's part of what we need to really look at. And the examples that we put on the slide was like risk and the risk adjustment, value-based care movement, those kinds of things. So who the work group members are if you have questions.
While Kinlaw's getting set up, I'll have to tell you that one of the work group members online said the doctor will be using an EHR that uses CMT linked to SNOMED CT mapped to ICD-10. A little coding humor. Yeah.
So I'm reporting for group 4. I've listed the members here. If I said anything wrong, please chime in and correct me. So on the first question of additional research, we mentioned it's time probably to start thinking about some pilot sandbox demonstration study in various segments of health, like healthcare, public health, or clinician pairs. And hopefully these studies would shed light on this list of questions: where the problem, how do you solve the problem, and what are the benefits, including even like an ROI kind of potential cost saving study, and also to document the information gain that is possible with ICD-11. So we think that the key benefits might be different. In some areas may be greater, like mental health, safety and quality measurement, social determinants of health. And one overarching benefit would be probably it's easier to integrate the administrative codes with clinical coding, like some. And we also discuss about some benefits may take time to accrue. It may not happen on day one, obviously. Next slide, please. So a further thoughts on the research question is that, we can kind of flip the question around to think about what are the costs of not adopting ICD-11. So we at least think of two costs that would be accrued. Like, because ICD-10 will not be maintained going forward, so anything we do with ICD-10-CM going forward will be more difficult, first of all, and will be wasteful in a way, because going forward we're going to dump it and move to ICD-11. So that is a potential cost of not moving to ICD-11. Of course, another cost of not moving to 11 is that we're missing an opportunity to take advantage of the new knowledge and capabilities of ICD-11. And we also put in a rhetorical question, say, okay, when do we decide that research is good enough? Do we always and say, okay, we want more research, and then as an excuse to procrastinate? Or we say, okay, we have enough data now, it's time to move on. Next question. Next slide, 6 slides. So about what is needed to ensure we don't need a CM. We didn't talk a lot about this, but then we did comment that the burden of transition should be on the system, not on the clinicians or the users of the codes. And we do need to customize messaging, training material so that it will work across specialties. Next slide, please. So which stakeholders likely to assist? So in general, we think that those who are benefiting from the current system will obviously receive change, right? And we have some groups highlighted here. And the bullet points below in italics, they are the kind of response we would like to use to answer to kind of lessen resistance. So data is likely to resist because they need to implement a new system. But then we say, of course, if you have better data, you have value-based data capture, then you can improve your adjustment. How about that? That will save you cost, right? And public health data suppliers might resist because they need to code in a different system, right? But then in ICD-11, we can give you automated coding, and that will help you simplify your coding, right? As a benefit to moving. Next slide, please. So we spend a bit of time talking about clinicians because when the move to ICD happened, clinicians were quite vocal, saying, okay, we don't want a new system, right? And the answer to that is that we say coding should happen seamlessly with clinical documentation, not as an additional burden, because one solution possibly is automated coding, right? And anything that can reduce the burden of the clinician is always valuable. And of course, we have to sell the benefits as well, because all capture of detailed clinical data can only help with the clinical care process. And also, when things are coded in ICD-11, they should be easy to find because they're at a finer grain level of detail. And hopefully that will kind of sell ICD-11 to clinicians. Next slide, please. So what is this question? We said, okay, generally we would like to sell ICD-11 is that it will satisfy the need for modernization of healthcare and health information applications. And we should, of course, demonstrate the benefits of to provider workflows and other things. And we also had a comment that it's not realistic to hope that people would voluntarily adopt ICD-11. That can happen. Probably we need some kind of rulemaking to dictate that. And also, we highlighted the fact that we need different approaches to different groups. And in case there's this misinformation and disinformation, we're prepared to handle that. So the final slide is that the key is modernization is needed. We have to move forward to ICD-11, not over periodic tweaks and so on. So 11 probably just a shift is a better answer. And targeted research, and we have to standardize the messaging. And we notice no major divergence of opinion in our group. Thank you.
Thank you. Well, Sue is coming up. Can someone in the room definitively answer the question, when will ICD-10 no longer be maintained? Does anyone have the answer to that?
It's already.
Okay, so the answer to the person
Not being
online is
yeah.
ICD-10 is no longer maintained.
Right. It's the implementation of ICD-11.
As of January 2022. That's your answer.
All right, I'm Sue Bowman, and I'm going to report on Group 3. So in the first question, what are the most important research questions remaining? One of the ones we talked about was, what is the impact on practice expansion? How is that going to be done? How is post-coordination going to be handled? Claim forms, EHRs, et cetera. For some use cases, would there be value in coordinating certain concepts for the US just because that would make sense for some of the concepts? What is the role of automated coding and the impact on EHRs? You can see some of the themes across some of these now. We thought we needed stronger evidence that US clinical modification is not needed. Agree that Quinoa's research was a great first start. We felt like it needs to go a little bit deeper and evaluate what actual clinical concepts are in ICD-10-CM that aren't in ICD-11, address things like it's because of changes in technology and understanding of clinical medicine, and is that the issue? And of course, then you would want to move to the ICD-11 structure. Or is there something else? So next slide, we go into a little bit more detail on that. We thought we needed a comprehensive evaluation of the impact, including an analysis of the clinical concepts, as I just mentioned, that are not in ICD-11. What's missing and how important is it? We heard some comments this morning that we don't want to just regurgitate, ICD-10-CM into a US linearization of ICD-11. There may be things in ICD-10-CM that are not being used, that aren't really have proven to be valuable. Let's just get rid of them, not worry about that as we move to ICD-11. Are some of the concepts in ICD-10-CM handled differently in ICD-11, like laterality, for example? Or is it a severity or staging that's handled differently in ICD-11? There's been a lot of content in ICD-10-CM that's been asked for by medical specialty societies. What would be the impact on those groups of not including it if it's not in ICD-11? And are the US concepts that are missing, are they missing in the foundation or the MMS? That has implications for whether a linearization would address it or not. If it's missing from the foundation, that's a bigger deal. We thought we needed a better understanding of what the governance process would look like if we don't have a clinical modification. The update schedule, for example. Right now, US updates ICD twice a year. Is it going to be a problem to go to a once a year, or if WHO is overwhelmed with requests, maybe even less frequently than that? What is the implications of that? We thought that the CDC should explore with WHO sort of options for incorporating country-specific clinical detail. We talked a lot about a US linearization, but is WHO open to that? What are other countries planning to do who currently have a clinical modification? Should the CDC collaborate with some of these other countries and sort of go to WHO with a common approach for how we're all going to handle the details that we need for our specific countries? What US governance process will be needed for submission of code proposals, regardless of whether we have a CM or not? Are multiple US citizens just going to write to WHO and ask for variations on the same theme, or is it going to be funneled through some central coordinating center? How is that process going to look? And we thought full mapping and electronic tools to support the mapping would be needed. Sure. But that was kind of the question we actually discussed the most. The next slide, what stakeholders are likely to resist ICD-11? We talked about physicians, health plans, need to get EHR vendors on board, need communication strategies to debunk myths and point out the value, education. And a lesson learned from the ICD-10 transition is not to make any benefit claims that cannot be supported with evidence. And the next slide, the last slide, what's missing? We've actually focused on representation process in that discussion and felt that we needed additional representation in this process from the Indian Health Services, practicing clinicians, medical office, billing personnel, EHR vendors, that list you see on the slide. And that we needed to understand how the EHR functionalities would be impacted with the transition to ICD-11. And that's the end of my summary. Thank you.
Hi, everybody. My name is Carmela Cuder, and I work at ONC. And
Can you spell that out for everyone?
Sure. It's Office of the National Coordinator for Health Information Technology.
We're getting feedback that people are having trouble online hearing us.
Oh, okay. So I'll speak up, and I hope I don't blow out the folks really close. So I'm going to just try to, you can read the slides, and I'm going to try to just highlight the things that we haven't heard before. So for our first question, what are some research questions you'd like to have answered? And we started talking about, hey, show me the money. how much is this going to cost in dollars and time for each industry segment? That would be interesting to at least project or predict. Managing the time, the overlap time, the transition time of when you might be doing quality reporting or any kind of reporting. You have some data coded one way, some data coded with 11. When we talk about post-coordination impacts on primary care data collection, we hope that it would not have tremendous impact on primary data collection. They think about health information exchange and what goes over the wire when you're sending, say, a problem list or something, or a transition of care document. What exactly is it that gets exchanged? And what's the impact on public health and research? We thought another interesting area of research would be to explore whether there's opportunities to correlate SDOH data with health disparities. And then, of course, the US linearization pros and cons. Next slide, please. So what we thought would be needed to ensure we don't have to go to a CM is a well-defined, tested, responsive, robust, and trusted maintenance process. And that we would most likely have to have some kind of US coordination center or community of interest. Sue, you alluded to that a little bit too. Next slide, please. Stakeholders, the usual suspects, the ones who you think might resist. An addition that came out of our group is we thought about rural health systems and small healthcare delivery systems that might not have the resources to train and pay for changes in coding requirements. And we thought a key benefit for ICD-11 is that it's computable. It comes with content and tools. We hope it's the last in the ICD update. And another thing is that hopefully, if we all are using around the world the same code system, we can have more international comparability and we can increase our pool for research, for all kinds of research. So we thought that is another possible benefit that can be described. Next slide, please. So what we thought was missing, and I've listened to the discussions back and forth about, do we really need to know that everything in ICD-10 CM is supported in ICD-11? Maybe not. Guidance for a longitudinal data comparison. You're looking at data across 10 years or something like that. How does that work? Artificial intelligence implementation support be something could be leveraged there. And then also federal agency funded pilot test for the whole maintenance process. We thought it might be interesting to pilot the maintenance process, not necessarily the implementing, jumping into ICD-11.
So I'm actually substituting for Amy Siddipati, who was the recorder on our during our group and is not here. So I agreed to present this information, but she's here with us. So I'm sure I won't get everything right. So if she would like to supplement what I say, that would be great. There is a lot of agreement between, can we have the next slide, please? There's a lot of agreement between what you all have talked about, and I won't really hit those redundancies. I want to just emphasize a couple of things. One of them is that I think there are some real potential benefits of ICD-11 that weren't part of ICD-11 that need to be emphasized much more. There are benefits substantially in terms of caseness, and I think that's a big change. I also think there are huge benefits potentially in terms of social determinants of health and the way those are available for coding and could be sharpened even more in ICD-11. There's a whole chapter on factors influencing health status and encounters with health services that's really quite comprehensive. And I think it needs some reworking to articulate a conceptual model of social determinants and health equity in a way that we would like to see it, but I think that could be done. I think it would be a major contribution. And, that is even without including practice to all of the ICF, the International Classification of Functioning, Disability, and Health. I think that's an area that really is exciting and could be seen as a real benefit for the system. More emphasis on population health, other areas like oral health can be incorporated more easily. I think that what will convince ground level users is if they see a benefit to them and a benefit to their patients. Otherwise, it's just more administration. And it's really important that we investigate whether the downstream impacts of coding, such as disease surveillance, payment, quality metrics are affected by ICD-11 and how those might require rethinking. So Amy's point was really that coding is not after the fact, like in an EMR after prior to hitting a claim, but really it switches on a whole lot of EMR functions related to decision support, registries, and more. So a significant difference between the ICD 9 to 10 transition and the ICD 10 to 11 transition is the much higher EHR use in the United States and the downstream dependencies on ICD, of which there are thousands, and some of which are tied to healthcare delivery quality measures that are then tied to payments. And this is for all healthcare systems in the US. So the cost of change may be pretty significant in the United States. So next slide. These are some other issues. I think this is mostly things that we've talked about. I think it's important to deepen the evaluation of gap analysis in healthcare delivery domain, again, because of EMRs, and do more thorough analysis of the published literature as well as working knowledge to identify gaps in content coverage. If we could go to the next slide on resistance. So part of what I want to say is that I'm Jeffrey Reed. I didn't say that in the beginning. I'm Jeffrey Reed. I have worked as a consultant to WHO for 15 years. I was the person who coordinated the development of the mental and behavioral and neurodevelopmental disorders chapter of the ICD-11. I'm part of the Medical and Scientific Advisory Committee for ICD-11. I am a professor of medical psychology in Columbia University Medical School. So I have a lot of knowledge about the ICD-11, but mostly about its clinical application. And so there is a real difference knowledge set in terms of clinical application and coding. What I would say about some resistance is partly that you all are used to a structure where you interact with the US government about how ICD goes, and you have a process for doing that, and you kind of know how that works, and you come to these meetings and you look at the things that are published in the notices where they are. So then if you really start to use ICD-11, this process is going to be much farther away and much more mysterious. There will be, an idea that somehow people in Geneva are controlling some of these decisions that are relevant to you. And that's going to be really difficult for a lot of people. The US doesn't ever sign any UN treaties because the US doesn't want to allow any international authority to have authority over what the United States does. And I think that's going to continue to be a bitter pill. So there's a part of me that can't even really imagine that happening. But I just want to put that on the table because I think it's a reality. And then, the other things that other people have already said about all the stakeholders that currently are invested in the current system. The physicians I know who work in group practices primarily were very upset about ICD-10-CM and the way it was implemented. I mean, they had to carry the cost of ICD-10-CM implementation. It was tremendously expensive for them. They didn't really see the benefit of it. So I don't see that there's that much of a plan for doing it differently. And so if it's just, again, going to be pushing the difficulty and the cost of the transition in terms of the implementation down to that level, I think it's, again, going to be really hard. And I don't see why we wouldn't have the experience again of continuing, well, let's do it next year. Let's do it 2 years from now when we're not in such a complicated environment or there's a pandemic or something else. And so, one estimate that has been talked about here so far is that, you could be implementing IC 11, 15 years after it was approved rather than 23, but still that's a long time. So I would like to think about how we do it faster, but I think that really is going to involve giving better support for people who are responsible for this on the ground piece of implementation. Let's see if we have anything else. Final slide. Let me use my last couple of minutes to see if Amy has anything that she wants to emphasize, because there are a whole bunch of examples that she had included that maybe it would be important to say something about. Amy, do you want to make any comment?
Oh, well, thank you so much for the inclusion. And what I would say is what I've already kind of said before, that we utilize these codes now to drive real-time care. And as the codes are getting dropped, before they even hit a claim, singular codes are driving care delivery. And I think that's an interesting thing to think about when we think about just the impact. But there's a lot of opportunities to celebrate, which Dr. Reed has nicely laid out. Thank you.
Well, look forward to further discussion. Anything else you want to say?
Okay. So now we have a lot of new information. Just heard, a great summaries from the breakout groups that have been going on in the working group among these medical experts. Instead of having one big discussion in the room, we're going to have breakout groups. So we're going to break out into separate groups, both online and in the room. So here in the room, we're arranged at tables according to breakout groups. Online, we will have 3 breakout groups. Each of you who are committee members, work group members, and invited experts have been assigned to a breakout group. You have that in your email. Each breakout group has been assigned a facilitator. The role of the facilitator is really to ensure that in the limited time that we have, that all the voices are heard, that everyone has a chance to express their opinions. Each breakout group also needs to elect or assign someone who will speak for the group in a report out, and someone to keep track of time, since we are going to have limited time. So if you're on Zoom, after my introductory remarks here, you will log out of this meeting. You have a separate Zoom link for your breakout group. And then, so keep track of time, because at the end of that Zoom breakout, you'll have to again log out of your Zoom breakout group and come back into the main Zoom meeting here, and be prepared to do your report outs. And so the discussion questions for this morning's breakout question. Slide for this. Yes. So the discussion questions, we have a half an hour to discuss these 2 questions. One is, considering all the information, we've just been immersed in, a lot of new information, new interpretations of the RFI readout. We had a wonderful presentation on the work done in the National Library of Medicine, great discussion on that. We had report notes from the previous discussion of these groups on, what are the priorities, what's needed, what's missing, how will the benefits be realized, and so forth. And so, considering all of that information, what are the most important research questions that need to be answered? Essentially, what's missing from the information set that we have if we were going to use the information that we have now to make policy recommendations? What's missing? So what other research questions need to be answered, and what are the priorities for that? And then, so that's the first question. And then if we say that we can identify the research questions that need to be answered, the information that needs to be gathered to inform policy, what's the path for that? What's needed to accomplish that research agenda in a timely manner? So we have half an hour to discuss these 2 questions. We're going to have these breakouts breakout groups. After the breakout groups, then we're going to come back and so I think now this goes to the slide just before this. Here we go. So at 5 past the hour, so we're now at almost at 35 past the hour. We'll have half an hour to discuss. At 5 past the hour, we will reconvene the reporter or the person speaking for each group will have a chance to report out on both the key themes of your discussion and divergent opinions. It's important to capture areas where there are differences of opinion or different perspectives from the perspective of different stakeholder interests. And so now I'll say that it's time, if you're in a Zoom meeting, please log out of this meeting, log into your breakout group. Thank you. Are there any questions in the room about the breakouts?
We asked for the other slide. Yep, that you asked us this morning.
Oh, okay. Yeah. Can you pull that up? Yep, it's coming. Thank you, Mickey.
Yes, so we've asked for in the room for
So hello, everybody. We're back. Our friends on Zoom are back in.
We're back.
What is Hey, everybody. We're back. We're back online. We're going to start the report outs on Zoom.
We are. Okay. So just for everyone who's doing report outs, your allotted time is 5 minutes. Okay. At 1 minute left, you're going to hear me say you only have 1 minute left. So take good notes, make sure you send those to Rebecca, everything you shared. But if we want to get to lunch, we gotta stay on target here. All right.
Linda, are you reporting out for your group? You there?
Do we have Group E to report?
Group E, is somebody reporting out for Group E on Zoom? Okay, let's go to Group F. Charles.
Charles, are you reporting out for Group F? Are you ready to go?
Mute yourself, Charles. There we go.
Yes. Hello. Hello.
Hi.
This is Charles Solly. I'm reporting for Group F. I apologize. I don't have everybody's names written down, but
Rebecca
Yeah,
Fine
Linda.
is reporting for Group E.
Who is?
Rebecca Fine.
Okay, thank you. All right, so Charles, go ahead for Group F.
okay. So I don't know if it's helpful to share my screen, but I will put on screen the notes that we were taking in real time. You'll see here that we kind of laid out a bit of a framework. It's repeated at the top and the bottom here and in kind of different language. But essentially the framework is trying to consider, the development of use cases, what's most important to be considered, what are the questions that we need to answer up front, and then mapping those to a couple of different types of analyses. So which questions can be answered kind of retrospectively using static or existing data, what type of data is needed, and then which types of questions would need to be answered using pilots with live data, and sort of a mock evaluation, I guess. So then we also talked quite a bit about the need. I think these questions are a bit out of order, and so I'm rushing through these, as you can see, but I think that the next most important thing probably would be to say that this question here about funding is probably the next most important, which is how much funding is needed to ensure any assessment of the effective implementation represents all stakeholders. And this is really ultimately an important question, you know, even in terms of equity, which we'll kind of get to in the next slide some more. So there were a couple of other questions here that maybe got into examples of, you know, these of important questions, which are, you know, how will community health clinics coordinate with electronic health record companies or software developers? So these are examples, a little bit of how do the smaller stakeholders, if you will, smaller, maybe in voice, how will they work with everybody in order to make sure that implementation is smooth? There was mention of a need for alignment across federal agencies, considering the universal data system and the guidance, emerging guidance from ONC, and that is particularly relevant to small and rural systems. And then, you know, this is, you know, we heard kind of repeatedly, there were questions around implementation. What are the education resources that are needed for facility coders? What materials are needed to support basically all of the users or other stakeholders? Those are outstanding questions. And then how will we know that, you know, another question is, how will we know that the ICD-11 has closed these gaps in understanding about social needs? Examples of those are, you know, transportation and food services, especially because my understanding is that those are often kind of captured through a complex combination of billing or of codes, and that they're not, and this I'm familiar with it, they're not currently a part of most claims and billing reimbursement. And so they're not likely to be in static or existing systems. And then I think there was a little bit of a question about coordination there with social services or benefit. So recognizing that I have 5 minutes, I'm not really sure where I am in time. Let me move into what is needed to accomplish some of the national research agenda that would hopefully accompany, you know, include some of those questions. 1 minute left, got it. So I'm going to reiterate that we'll need adequate and significant funding. That's critical to ensuring equity and representation in any of these assessments. The amount that those awards look like is probably somewhere between $1 million and $50 million in research awards, and that we're talking about significant funding essentially. We're suggesting an RFP for multidisciplinary research proposal that includes multiple stakeholders, again, adequate funding, looking at retrospective and real-time systems, look for potential funders, an RFP for developing education and training materials that includes, again, key stakeholders as well as these smaller entities or stakeholders, the constituents in this. And then we would like to identify pilot participants and kind of ultimately develop something of a shared knowledge base or a means of kind of coordinating the data and information that comes with this. Thank you.
Perfect, thank you.
Rebecca Fine, Group E, Linda Kloss's group. Unmute yourself.
Sure, thank you so much. And let me go ahead and I'll share my screen as well because I took notes right into the breakout session question template. All right, I hope everyone can see that all right. So looking at the first question, what important research questions are remaining and what's needed? You know, the group kind of agreed that the idea of having, you know, the piece of the pie was great, but we need to take a deeper dive into other slices, not just focusing on mapping from ICD 10 to ICD 11, but what are the gaps, probing what weaknesses ICD 10 had. Really narrowing in on the impact on specialty professions, independent providers, and really asking ourselves, is this going to reduce the burden on providers or is it going to increase that burden? We also discussed that implementation for a post-coordinated system is not simple, and we need much more details on the technology and how it's going to achieve the results that we're hoping to see. And that we still have questions about the rules for extensions, and that the current web browser is not sufficient to meet the needs for the people who are generally interested. So much more deeper dive into the tools that we're using to help educate not just the people on this call, but the broader audience. And that leads us to when are we going to start education generally? Are we going to be designing a system where we have the same sort of education, or are we basing it on the needs of the end users? And how does that tie to pilot studies, including dual studies looking at ICD 10 and 11 in terms of education? Furthermore, how do we update and modernize the governance of ICD 11? Do we really understand the coordination of maintenance activities and the impact that the maintenance process may have on people who have already implemented, or once we get in there? Looking at the sort of approaches for implementation, looking at a phased approach versus sort of an all-at-once approach for the change, and what we would be able to know as far as impact and mitigating that impact. We need a lot more information for the technology arm of implementation. What tools are needed? How do we make sure that the approach for technology and making that accessible is equitable? We had a short discussion about tying anything to certification creates two systems, because not everybody uses or applies for has certification needs. And then we kind of ran out of time before we got to do a deep dive on this, but for the national research agenda, making it a priority and making sure that it is fully funded and funded well enough to really do the deep dives that we need. I think one of the key questions that I am still looking for an answer for, and the work group, our subgroup needed an answer for, is who is responsible for the coordination of all of this. It seemed like there had been some previous work done and some information that had been published on that, but at this point, does that need to be reevaluated? And again, ensuring that all the parties that are participating in the getting the sort of implementation planned, as well as those who are going to be the end users, are being able to participate, and that the entities responsible for coordination aren't sort of leaving anyone out of the process. And then really having a defined end-to-end roadmap is really needed before we start any implementation phases.
Thank you. Group G is Maddie and Debbie Adair.
Hi, this is Debbie Adair, and Mary Lou, I think you have the slides. So I am the Executive Director for Health Information Management at Mass General Brigham. So to kind of pick up where Rebecca left off, we started really talking about the governance. And with all of the information that we've collected, the RFIs, there might be another one coming, all of the work from this work group and others, there's a lot of ideas and a lot of areas that we need more research and questions answered. So who's going to do this? Who is going to be assigned these tasks? How is it going to be accomplished? To Rebecca's point about the governance related to implementation. So are we going to take all of this and prioritize it, or are we going to try to do it all? And so, who's going to coordinate, organize, gather? We also mentioned a roadmap, a timeline with milestones. Really, if we're saying 10 years out, we really need to have this laid out and hold ourselves accountable. Then in terms, research questions will inform the governance. And, we talked about, if that's the case, we really need a complete mapping. That's going to be a necessity because the transition is inevitable. And the, various government agencies are going to have to, complete this and participate. Case studies, funded projects, vendors, stakeholders, not only ICD-10 to ICD-11 mapping, but also compatibility back to ICD-9. Is the intent to have direct mapping similar to GEMS. And the same thing with, the mappings with SNOMED. So the same issues. Looking at, how we're going to be able to, what we really want to make sure is that we're going to be able to trend this information over decades, over populations, multiple generations. That would be our goal. So we really need consistency in concepts and trending. SNOMED, it was mentioned, SNOMED CT may be an argument not to have the clinical modification and leverage the WHO version. Need for centralized committee center work group, again, a governance issue, could be more helpful than what we have now, which is, some lack of resources. And so need better organization. We need a really dedicated center devoted to support this work, along this timeline to make sure everything gets accomplished. And then, we mentioned an inventory. So who are the participants, the key stakeholders, who, the government agencies, and who is going to provide the oversight and coordination. Timing, communication. We talked about limited resources in certain areas. We have to worry about workforce staffing, some, organizations that, would not have the finances. It would be a burden, and who's going to bear some of that burden. And then in terms of critical care providers, patient care providers, we talk about them, payment research drivers, but one of our members, questioned the clinical care benefit and questioned that. So the experience hasn't been seen, and so really need to show more benefit on that in that space. We talked about the fact that ICD-11, it's a digital classification system, and we need a system to leverage a common software to facilitate for stakeholders and make that publicly available, free to the public, to integrate with FHIR and other applications and tools that don't require financial tools. And then post coordination, understanding what is necessary for pre-coordination. Pre-coordinating terms is having standardized terminology. Also, looking to see if other countries have experienced payment reimbursement, issues or applications, and then really to get EHR developers, vendors, and other stakeholders, that are involved with revenue cycle development to get more engaged, and for us to engage them more sooner than later, because they really are key players, and we need to make sure they're on the same page and are strong supporters of moving forward with this. And also lastly, artificial intelligence is really something that is central to moving ahead with automated coding. So that's it.
All right. Thank you very much.
Okay, we're going to start with the in the room groups now. Same principle, 5 minutes. Sue will still call out when it's 1 minute. Let's start with Group A, which is Tammy Love is the presenter for that. And you can still look, and you will see that they have notes or slides up.
Yeah, I brought my computer up just in case I couldn't see that. So some of the things have already been touched on in terms of what has been shared so far in earlier today. So the NLM study that was shared earlier, great information, but data expansion is really needed. AI capabilities and the exploration of what the possibilities are to help with this implementation, and being mindful of those stakeholders that may not have access to AI and what that means for them. Consider decoupling definitions from MS. We need convincing cases of how to do this. So what does this look like based on analytics? Need for understanding what has been used with ICD-10 to help inform and target the intent for ICD-11. need research on medical education, medical school education. Dr. Lindsay brought up that, we need to teach or help physicians, clinicians know how to document, regardless if it's AI or somebody on the back end pulling this data. Funding to pay for the research by payment systems, hospitals, et cetera, all of the providers. And what is needed to accomplish a national research agenda? We need to get to this as we didn't spend as much time on this one. We've already talked about an RFI for a longer time frame and making sure that we target the audiences that we didn't hear from this particular RFI, and then again, dedicated funding resources.
Thank you very much. Speedy time. Thank you. Okay, clap. C, group C, we're gonna do group C. We need to get you set up. So Carmela, right in front of me.
Again, so the research questions that we thought were remaining that we heard maybe together in. Oh, sorry. So our research questions that we're reporting out are, the first one is, what is the set of codes, STEM, extension, foundation, that would be best suited for use in the United States? So some of the things we might look at is what's the frequency distribution of ICD-10 CMs over time, and what coverage would be required. So we understanding the frequency distribution isn't going to tell the whole story, because we also want to look at what coverage would be required for, say, rare diseases or for certain populations. So there might be a certain geographic area that you see more incidence of some things than others. And all feeding that into a pilot. So a pilot hopefully would be part of the research. The second research question that we thought about was, will financial incentives make a difference? Is there a combination of financial incentives and documentation standards that would make implementation in clinical settings feasible? Looking at make sure we look at small practices and ways to mitigate costs. For example, publication of standard mandated mappings, say that CMS would require. You will be paid if you use these. And also training and education. And then our last research question we thought about was, how would ICD-11 be used with clinical documentation standards? XNOM NCT, BLANK, and RxNorm. So how would they all work together? So then when we looked at the what's needed to accomplish this national research agenda, no surprises here, but funding and making sure that the funding is directed to the right sources. Someone would have to define the right places. And then authoritative coordination, understanding that ICD-11 has the potential to be used for far more use cases than ICD-10 CM is.
E, which is going to be Denise Luck.
Hello, everybody. Team B was quite active, so I had trouble capturing our debate, and I'm going to end with kind of our divergence point. But we'll start with the most important research questions, and we felt extending Dr. Fung's research to expand the scope and focus. Going end-to-end, patient longitudinal record, EHR to codes, and test that. Data sources evaluated for representativeness, which we talked about this morning, but I want to throw out, because I'm a data person and I work with all payer claims databases, it's possible to get multi-state ABCDs to do some of the feasibility testing using various data sets. Our group felt starting from scratch, like taking the medical record, dual coding it, and making sure it's accurate, and making sure it's better in ICD 11 is one research approach. We need use cases to analyze distortions in the ICD 10. We heard a story about pregnancy diagnosis, and for cardiac cath, coding all women pregnant to get the pregnancy test paid for the cath is a distortion in ICD-10. And so we need use cases to look at those distortions as we go through research. Some felt strongly that CMS needs to identify priority research cases and use cases according to its strategic roadmap and verify that. So I think everyone at the table felt, and I heard this over and over, a central coordinating entity with the authority to design the entire rollout of a multi-year complex program. And I add sort of a hub and spokes model. Needs to have broad representation that's designed to accelerate, not stall implementation, evolving process, so adaptability, a high-level model for educational messaging components for each segment, a playbook for each of those segments with roles and responsibilities, emphasizing statutory authority, EHR, HIT certification as well, whatever tools in the toolkit. Research, secondary research capable. We need use cases and user segments for priority populations. We heard that earlier, research. And can we push detailed coding data as a benefit for research? We were trying to bring incentives for getting better research data. That's we may need to talk about that a little bit. Private collaboration, we need multi-source funding, federal agency funded pilot maintenance process. We need to test the capacity and the cadence of WHO to take on any maintenance before we make big decisions. Automated coding within the workflow, EHR or other systems, demonstration. Does it work? What will it take? So this is the bomb. The impact of I-11 on other code sets. What are the value and costs? Can we do away with SNOMED eventually? Distortion and conversion between these code sets and code direct from the medical record? Or do we need the two, and can they coexist? And can there be seamless integration? This is a real, that hits some fireworks at our table. Reimbursement is based on coding. And so, SNOMED came in there as what role does it play? Specialty societies are very important. And whatever conversation goes forward, we have apparently quite a fragmented universe with different specialty societies creating different standards and codes, and I may need some help there in table D. So anything else, group D? Do you want to? Okay.
That piece, group B.
Hi, my name is Jim Case. I'm a chief terminologist for SNOMED International. I'm also so no bias here, none at all. I'm also a member of the Medical and Scientific Advisory Committee for ICD-11. So we looked into a number of areas. The first research area that we looked into were the tools that are needed for implementation, and the focus was really on some of the parties that might pose some resistance, which are the people that actually have to do the coding, especially if you're getting post coordination. And so what are the tools that are needed to try and facilitate the use of coding at the user interface, or to put that coding in the background as much as possible in order to gain more acceptance of that. The second area that we looked at is the governance process. It was mentioned before, the ongoing maintenance. I think that the rollout of ICD-11 at the beginning is going to identify a lot more gaps than you're going to be able to find in the initial implementations, and how can we respond to those needs in a rapid manner to facilitate the use of that form of reporting. And as was mentioned in Group G, given the fact that SNOMED is implemented in a lot of systems right now, do you need to move to CM when you have a clinical reporting system that already handles that, plus the fact that SNOMED has crosswalks to ICD-10 CM currently and is working on one for ICD-11 MS. The other research area that we looked at was how do we develop credible evidence of the value of ICD-11 over ICD-10 CM? And what type of use cases do we need in order to do that type of research? And then the ability of ICD-11 to address the health equity, population health, downstream or social determinants of health, et cetera. How well does it cover that? And what needs to be done in order to bring it up to the level that it meets the needs that the US has in those areas? And then lastly, research needs include how systems that require pre-coordinated codes can handle post-coordination, and what kind of changes are going to be needed to those systems, and what's the impact of those on those systems when we're placing a lot of emphasis in ICD-11 on post-coordination. So if we can scroll up. A lot of these needed things have already been covered by some of the other groups, but the first is we need to identify who benefits in the move to ICD-11 and how do they benefit, and to try and quantify those in a way that is compelling for people to say it's worth the effort to go through this. And then after we identify those efforts, then we can say, okay, how much is it going to cost to pay for it? And how do we make that easier? These implementations are going to be especially onerous for small entities that don't have the funding to make large scale changes. And how can we develop that coordination with the people that are paying for it to facilitate that? And then where does the coordination occur? Does it occur solely at the federal level, or is it a combination of a public-private relationship? And who are the components of any type of a combined public-private interaction? And of course, communication is going to be very important, because we need to be able to communicate those benefits as much as possible in advance of trying to develop any policies, because people are going to push back regardless of the policy if they don't appreciate what the benefits are. And some communication on what are the anticipated transition timeframes, so that people can get an idea of how long it's going to take for them to move from where they are now to where we want them to be. And then it's anticipated that voluntary acceptance is probably going to be unlikely. And so there may be some legislation that's needed, and how do we make sure that that legislation, again, it's not onerous on especially the smaller players who are going to be severely impacted. So that is the end of ours. Thank you.
That over to you, because we have 8 minutes left. Oh, I'd be happy to. Join us. Okay, so we have okay.
Can I just make one clarification? Because we had this nice conversation, SNOMED. But
yes. You stand up, Tammy.
So Tammy, stand up so they can hear.
The point about SNOMED, the underlying point I think was important. The point is, any code set, regardless if it's open source or free, has to be paid for somehow. There's a vendor that's going to have to purchase it from, it needs to be integrated. So the study, I think, was looking at ICD-11, is there a way to reduce additional external code sets to reduce the overall cost that's already being for the business? So that's the frame, right?
Thank you.
Which is an important way to look at this, right?
And the translation between.
You have to speak up.
And the translation between those conversions, we lose things. We lose.
Other questions or comments that people want?
Questions from? Not from our team here. Okay.
Since I was the one that interjected in our group the idea of a public-private collaboration of some sort, could be an independent nonprofit. Just, my bias, I have to be current chairman of the Sequoia Project. And for those of you that aren't familiar with the history of that, there was something called the Nationwide Health Information Network that the federal government was trying to implement to create nationwide interoperability. And they recognized, I think appropriately at some point, that they weren't succeeding. So they externalized it. And, and a nonprofit public-private consortium was established. That would be the Sequoia Project, which has been very successful in promoting nationwide health information exchange and interoperability. So, when you think about the tremendous amount of funding and resources that are going to be required to make this happen, the implementation of ICD-11, I would see how we can avoid tapping into the private world for some of that, because they will also benefit from this in different ways.
I'm going to raise a question because it came up to see what people thought, and I can't remember which group it was. Oh, I think it was me that talked about the need for legislation. And so this issue of something being mandatory, something people being in compliance, people in regulation, you have some sense of where you want to see these kinds of things. Is it at the level of payment? Is it at the level of the federal government, that has some idea about, what a standard is going to be? Any thoughts?
Yeah, be the HIPAA transaction code set.
Well, yeah, because right now that is a mandated code set, right? But I think I know where you're going with this, Mary Stanfield. I think I know where you're going with the complexity of that, because there's multiple uses, use cases, and different benefits of each, and you don't want to end up with different systems. So if it's mandated for the HIPAA transaction code sets, but not for, right, then we're not using it for, some of these other uses, we could end up with more of a Tower of Babel than we have now. And that we don't want that. So how do we avoid that? Maybe it's
Someone online, Linda. Unmute yourself.
Yeah, I'm really happy that the governance question has come up, because this too was wrestled with by NCVHS in a 2018 report on health terminologies and vocabularies. And in a earlier set of recommendations from AMIA and AHIMA together, calling for a public-private partnership to collaborate terminologies and vocabularies. Because when we look at, and we laid out in that 2018 report just kind of all of the fragmentation, and the issues go beyond adoption of ICD-11. It's taking advantage and getting the most benefit from the full range of tools that we use. So I think this is interesting that it came up in every group. And I know Rebecca made the comment in our group that, it probably is the most compelling issue to tackle, because we won't have a smooth implementation if we don't have a different governance structure than we had from 9 to 10.
Unless there's something left, I think we should close out, so we can launch on. All right. Thank you, everyone, for your hard work.
Thanks, everybody, very much. We're now taking a 45-minute lunch break.
Yes. Patty, just let us know you can rest. And you hear us on Zoom. Charles, somebody let us know. Lou, can you hear me? Stella?
Yes, we hear you. Yeah, we hear you.
Okay, thank you. Thank you. All right, we're getting started now. Comments.
Okay, so I am here to introduce, I think, the issue of continuity and sustainability. So one of the things that we definitely don't want after we've gotten started here is for everything just to come to a screeching halt. Now, Jamie's already told us that the work group has been reauthorized, so that's good. Okay. But with that, and some of these issues have already come up today, we're going to do another breakout group when we talk about some of these things. Can I have the next slide, please? So we've identified a whole bunch of research questions, stakeholders, but what can we do to maintain the momentum? How can we keep this moving forward? Now, NCVHS is advisory. They're advisory only. They've taken the lead by establishing the ICD-11 Workgroup on timely and strategic action to inform ICD-11 policy. And the workgroup's going to report back to the full committee. We reasonably expect the full committee will make recommendations to HHS based on these activities. But where is the U.S. policy going to come from? So I want to thank Michael for bringing up the issue or the option of public-private, right? So we would like that discussion. Who is best positioned? Is it federal? Is it public-private? If it's federal, is it NCVHS, ONC, NLM, CMS, or some other national steering committee? Be willing to think outside the box on that one if you're looking at when you're discussing who is best positioned to lead the overall project, and then also think about specific parts of the project, right? Because this is going to have to be a multidisciplinary effort. There's not going to be one group that's going to do everything. We want you to talk about, are there organizations and agencies that must be included for the longitudinal success of ICD-11? So are we missing anyone? We've talked a lot about different stakeholders. So can we put some specifics around that? The third bullet is maybe not as easy for us, but what do we need in the United States that is different than what other countries might need? So you have to think about their healthcare systems, how they utilize ICD. What do we do here that's different? Okay. So, and I think that's very important because, again, it impacts our planning as we move forward. We don't want to reinvent the wheel where things are the same as other countries. We don't want to redo that work if we don't need to, but yet we want to make sure we're addressing what we need in the United States. And then this last bullet I will tell you is a bullet that I added because I want to know what are the essential next steps in some priority order so that we can start moving forward instead of having a really, really, really long list. If people in your group can talk about, here's what we got to know, here's what we got to do in a priority order. There's so much. We have to start trying to organize it. So, Jamie, Rebecca, I don't know if y'all wanted to add anything to that.
Not in terms of the content of the discussion.
Okay.
Yeah, but I do want to just thank you for emphasizing that the National Committee on Vital and Health Statistics is an advisor to the HHS Secretary. We do not implement. We're not an implementation or operational arm. So that's just the reality. And we do have a slim amount of resources to continue for another year. We have approval to continue for another year. Out of the committee runs out of the Assistant Secretary for Planning and Evaluation. So just for context, there is still some more convening capacity for another year.
Thank you. Okay.
So these questions are slightly different than the ones that were posed earlier. Are these the replacement questions or an addition questions?
I think this is an amendment to the questions that were posted for the afternoon. Can we bring up the slides for these breakouts, please?
Can I ask a question? Is there any reason that we need to know anything about how to work with WHO? Is there anybody in the room that could tell us so that we're on the right path and not just doing a US thing, but we don't know? I remember this morning when Jeff was, Dr. Reed was making a couple of comments and I was like, oh, I didn't quite know those things. So is there anything that would be helpful for us to know?
Well, I don't know, Bob, if I can put you on the spot as the person who is really the central point of contact, I think, for us at this point.
Yeah, it's, I mean, there is a specific governance process set up by WHO, and there are several,
can you speak up?
There are several committees and work groups that evaluate proposals for ICD-11. Jeff, I know, and Jim said that the medical MSAC, Medical Scientific Advisory Committee. I sit on the Classification and Statistics Advisory Committee and the Mortality Reference Group. We do have some representation on the Morbidity Reference Group as well. I know Sue sits on that group. You know, we all work together to evaluate these proposals, the proposals that come in. The question is whether we want to coordinate proposals in some way. I think that goes to what was just one of the questions that was just asked, and how we want to coordinate those.
Thank you for that. And Vicki, thank you for that question. So I think, Matt, we can consider that question about coordination with WHO as a sub-bullet or an amendment to the question about overall how to sustain and coordinate this activity going forward, which is our theme for the afternoon. Next slide, please. So we are breaking out into the same groups that we had this morning. The facilitator role is the same role. Please make sure that all the voices are heard. We want to get all the perspectives with limited time. Now we do have a Zoom, we do have a PowerPoint template, but the use of that template is optional. So you can decide within your group whether you want to do a verbal report out or use the PowerPoint template. And again, so if you're on Zoom at the end of my little talk right here, you log out of this main meeting, you will log into the same breakout group Zoom link, which will operate the same way. And then at the end of time, and how long do we have for this? I think
25.
So this is a 25-minute breakout discussion. So at the end of 25 minutes, you log out of your Zoom link and back into the main meeting. It'll operate.
And there's
in the room here.
Oh yeah. Oh yeah, and apparently we have a break at 2:15, so you can use part of the break.
Okay, so after this we go into a break, and so you can, if you want to use some of your break, to continue. Is that a 15-minute break?
Yeah.
So
we're reconvening at 2:30.
So right, so reconvening at 1:30. Bear that in mind. Same as this morning, one person will do the report out for each of the breakout groups. So, and one person should be maintaining the time, make sure that you're getting through questions, getting through your discussion, ready to report out on time. Next slide. So at 2:30 Eastern, that's after the breakout groups are finished and after our break. So we're going to take a break. Then we'll come back into the main meeting here. Slide. Okay, so we have two main questions. We've heard some sort of what I would call subsidiary questions under these, both from Susan and from Vicki. I think that, really we want to understand what organizations must be involved in moving forward. Are there specific agencies and organizations whose involvement is needed for specific studies? And this is referring to the information agenda, the research agenda we talked about this morning, we talked about in all your breakout groups, who must be involved in that agenda. And then really the central question, I think, in the afternoon discussion is the question D in the slide presentation here, how to coordinate and sustain this community, how to obtain needed information to support solid policy recommendations. We talked about the kind of information that's needed from many different perspectives. How can that be coordinated? How can that be sustained? We want to have a sustainable community. We want to continue this. As you heard, the work group has been renewed for the next fiscal year, but that doesn't do it by itself, right? So that's not the community. That's just the work group. So this is really what we want to discuss. Any questions on this breakout?
And I'm emailing you all Susan Fenton's slide now. So if you want to have that as there's sort of more nuanced questions, you should be getting that in the next 30 seconds.
Rebecca, can you just put it
Can you
up?
just display it?
Can we do the double display again? Yeah, we will.
Okay, so that will be displayed in the room and on Zoom. Okay. All right. Seeing no questions online or in the room, please go to your breakouts. Thank you.
Bruce, is the voice still
Yeah, no, this is good. Yeah, no, I'm good.
Lily and Nick.
Oh, wow. How very
Yeah, and we all look better from you.
Session breakout groups. Thank you everybody for rigorous discussions. We will start with the online Zoom breakout formats. And I'm not sure the order.
So Linda is Rebecca.
You're trying to do that with.
Be your person again.
Hi, Ashton, for our group.
Who is?
Ashton,
Afton, the floor is yours.
Ashton Dunsmore. All right, thank you. So Group E here, who is best positioned to lead the overall project? We thought it was appropriate that HHS would fund the initial coordination, and that it could come from this committee, but there's a need for a staffed coordinator and funding to expand the committee with task forces and some ideas for those task forces. One very important for a design of a governance mechanism going forward. The clinical efficacy effort that's been completed so far, a continuation of that, including identifying gaps. Very important to have an implementation roadmap. So basically all of the questions from this morning's feedback that everyone came up with would inform what those task forces look like. But then after that, there's a need for long-term coordination. Of course, political and funding hurdles to get over before we get to that point, which could be some task force work. But then that could be a new entity, public and private entity, to coordinate the long-term implementation of this. So stakeholders, I think this list could be a lot longer, but the big ones, providers, payers, policymakers, technology vendors, public health,
should all be included for the longitudinal success. This was not a question, but we just added in this bullet point of the need for coordination of terminologies and classifications. So that would involve all the agencies that help maintain those. And then lastly, actually, there's one more on here. So what is needed for the United States or that is different fundamentally here? I think we first need to look at the analysis of implementation so far and working with who on that. And I know there are some studies out there. I believe Linda in our group referenced Canada and maybe being able to look at that. But being able to look at that first and then determine what's needed. And then there is definitely a priority order, I think, for the next essential steps. One being what we started with, the funding of a coordinator to work, funding of a coordinator staffing the work of an expanded committee. And then designing a governance mechanism, continuation, completing the slices of the content and identifying the gaps, creating that implementation roadmap. Then after that, you can start to create a technology arm and identify challenges first, and then creating a toolkit for implementation of technology. Then there's pilot studies targeting all users, and then creating education, but being careful to make sure that's rolled out in phases and that it's audience-based. So we want awareness before training. And all of this, is in priority order. It could be iterative too, but some of these things need to be done first to inform the next. And that was our group. Thanks.
That would be, Amy said their group is ready. So that's group F.
Thanks for having us. Yes, I'm sharing my screen now. Thanks so much. Thank you for the team that came together to inform the work, which I won't go through in great detail, but I think represents everything. I'm Amy Sitapati, and I'm a clinical professor and primary care provider at UC San Diego. So in terms of the leading agencies and organizations, there is quite a list that's been assembled here for you to think about, including many who've been included before. So CMS, CDC, NIH, HRQ, FDA, HRSA, IHI, SSA, NCQA, AMA, specialty societies, the American Hospital Association, AMIA, AHIMA, software developers and terminology maintainers, EMR vendors, payers, patient groups, public health organizations, health research organizations, the AAMC, disability rights organizations, key foundations that could provide funding for initial priority areas and give us speed. And also don't forget Congress for congressional allocation of funds for some of the support. So those are some of our considerations. In terms of the poising of this is not a one, this is a many. So we would recommend a community multi-agency partnership. Regulation is key, and so we will need governmental inclusion there. We might consider agencies under the CDC, CMS, ONC. We should also reflect on our lessons learned and how to best mitigate some of the missingness that might be there and be more inclusive in terms of thinking through maybe any prior documentation, and maybe that would inform who else needs to be at the table. We think that the private-public partnership will actually give us a lot more speed and inclusivity. So, and then for the second question, we frame this as there needs to be a how. What's the governance, roles, and funding that will enable this to happen? And what are those key responsibilities? We need to coordinate that with WHO, who's at the table there and who should be at the table in the future. How do we think about inclusive partnership and participation in all sectors, including public, private, and the current partners for ICD-10, as well as state and local entities? How are those incorporated? We might consider breaking this to a viewpoint of, first, there's the implementation piece, but actually the longer longitudinal maintenance, and what is the structure in terms of governance, roles, and funding that really promotes that continuous life for this work. In terms of the what, there should be clearly defined goals and processes, phases, timelines, agencies, and very clear dissemination pathways that are transparent and open. That's our group.
Great. And group G. Is that Maddie and somebody?
Okay. Hi, this is Debbie Adair again. So we wanted to address these questions, who is best positioned, and similar to some of the other answers, we definitely thought that this needs to be a public-private partnership, federal and non-federal components. And we felt that it was important that it needs to be a separate, kept separate from any rulemaking. And looking at, other consortium of agencies under one lead agency, including health information networks, looking at tribal territorial groups as well. In terms of the organizations and agencies that must be included, so we were looking at, how do we identify them? We looked at, some of the, functions in the work about maintaining and updating code sets. The restructuring of it would then, impact on who's involved and, the future role for the cooperating parties. We've listed there. Updates in education, communication strategy, and messaging really needs to be looked at in advance with identifying some of these groups so that we can provide a full picture, a timeline. We need to address financial aspects and a full assessment of the needs to be communicated. We identified lobbyists, health insurance, trade associations, looking at communicating benefits, getting, how do we get these groups involved in supporting of the effort, trying to stay ahead of it in terms of finances and what needs to be factored and considered. Stressing values and the value and the opportunities that would come with transition to ICD-11. And then these are some of the organizations that we identified and that were identified in the previous report out, and some of the standard setting organizations as well. Next slide. And so in terms of what is needed, or what is, the United States in terms of being fundamentally different from other countries, we're similar with mortality and research. ICD is embedded in our payment system, with our CM needs. We'll have to address whether we, need CM or not. And then we don't have, it was mentioned in our group that the governance in the United States, we don't, kind of have with international agencies, and that there's a lot of coordination and outreach that we need to focus on here because of a lack of a single payer system, and that we have a very complex healthcare system with numerous stakeholders, no centralized health authority such as other countries have. So the experience is a bit different. And then in terms of next steps, we need to identify and find an entity to fund and coordinate all the needed research that we've talked about today. And that how can we increase, the visibility of these, the need for ICD-11, and, talked about, somebody like a Google or a Microsoft, would they be interested in helping? And then, the White House really to designate the lead federal agency. Determine, as I mentioned before, if CM is needed or not. And then the mapping would need to be completed. And then, important to create a timeline with what we need to do, who needs to be involved, how we're going to do it with the roadmap. And I think that's it.
Great. All right, so we're going to shift gears into the road. Thank you very much. Group A.
Oh, that's very
So that's why.
Okay. Slide 6. Okay. Okay, some of these things are a bit of a repeat. I think there's some of these too. So we didn't really say like who is best positioned to lead the overall project. We didn't say that, but we thought it was best to have a combination of public-private entity, and that who is to be determined to lead the overall project. So similar to how cooperating parties work in terms of the process. Specific parts of the project may also need to be determined as applicable. So involvement, I think a lot of these have already been named. We did include a lot of physician organizations as well, in addition to clinical data science organizations, as those continue to evolve. And then we also wanted to find out, specific studies, specific to these organizations that are involved. So we need funding for the studies, and what are the needs and interests to be gained by ICD-11 and the impact to each of these different organizations. And for longitudinal success, same groups will need to be involved, and then consideration of new groups as the process of implementation moves forward. And what is needed in the U.S. that is fundamentally different from other countries? A few things that we mentioned that I don't think that that we've heard all of these, but the clinical modification, certain things that MMS doesn't have, like social determinants of health. We kind of talked about that earlier in different contexts. And diagnosis definition could put clinician at risk and need to continue current diagnosis guidelines using the concept of highest level of clinical certainty in diagnosis determinative diagnosis. And then a governance group establishment, I think somebody else mentioned that as well, while a blueprint for proceeding is drafted.
We're all too sluggish to clap now. All right, Group B.
Just putting in a little last minute correction.
All right.
I think you need to move this one.
Oh, yeah.
On mic, okay. See that? Okay. I'm using a different computer than what's on there, so I want to make sure they stay connected. So first, what organizations need to be involved moving forward? After some discussion, we decided that perhaps the best agency positioned to lead this would be the National Library of Medicine. We decided that this agency has a strength at NIH as a neutral party compared to many other government agencies or outside the government agencies. The agenda of NLM is quite neutral, and they are also very experienced with a variety of terminology. So that seemed like a good position for them. However, we did also discuss the idea that there might be a new entity to be created, and we considered their potential attributes. This could be another neutral third party, perhaps outside the government. And this could be a group that perhaps focuses on where the data comes from. And also someone who would have a lot of concern regarding the stakeholder agendas for all these different agendas. So going on to the next point, are there organizations and agencies that must be included for the longitudinal success of ICD-11 implementation? I think, like some other discussions here, we essentially decided that every federal agency that touches healthcare is relevant, not only in NCVHS, but certainly in agencies or departments like DOD, VA, perhaps even the EPA, many different agencies that would be involved. Obviously, we would also want to have WHO involved as a critical participant. We would also think that we would really need a lot of the umbrella organizations that organize the stakeholders, for instance, AMIA, AHIMA, EHRA, and AHIP. So these would include, for instance, health plans, academic centers, health information management systems, and the companies that produce electronic health records. I happen to live about 2 miles away from Epic, so if you need a rep, I'll be happy to. In addition, obviously, we will want to communicate with the vendors that will develop and sell products related to all this change. That might well be a lot of software companies. However, we would also want to look at artificial intelligence partners and big tech companies, and certainly Google might well be included with that. But others as well. And finally, it would be very important to include state governments as well, so since they have to administer Medicaid, Medicare, and so forth. So finally, how would we coordinate and sustain this community to obtain the needed information to support our recommendations to HHS? First of all, we emphasize the need for a more extensive RFI, certainly with more time for people to communicate those documents and think about them. Another question we had is that, do we need to have an organization that is designated with authority and finance to make decisions and what it creates to get implemented? So I think that's similar with what we've heard from other groups here today. And that might be perhaps something like HL7, something like that, that could organize these things and make them happen. This might be, this sounds like it might be something that's different from NML, but perhaps NML would be, if you will, the strategic organization thinking about the planning and so forth. Perhaps another agency or group to actually make things happen, more of a tactical group that would actually make all this stuff go. And finally, we think that we really do need the development of an engagement plan for soliciting our partners. We talked about the fact that sometimes in the past, this group has communicated with different agencies and groups like we've been talking about, had a discussion, got a white paper, it went in somewhere, and then that was the end of it. So we really need to have a plan for deciding how can we move forward with this and really try to get things organized and make it happen rather than simply be some papers and that's it. So that is all for our group.
Answered questions. I'm listening about my voice being soft because my kids think I'm yelling all the time.
We really can't hear you.
Oh, you can't? I'm sorry. I'll really try to speak up. So our group answered the questions in a little different order and different collection of questions, but here goes. So the question about continuity and sustainability over time. we thought that there should be continued engagement from the organizations and individuals who are participating in this work group. And that one of the things we have to produce is a work group report, and that should include a proposed schedule of ongoing meetings and work sessions. We also thought that this group should take advantage of the online presence that's already there from NCVHS and enhance the existing work group website and explore some community collaboration tools where maybe we can, in between meetings or whatever, we can have a common platform. Also, obtain funding for sustained resource allocation to make sure that folks could get their travel paid for to come here, to come to meetings and things like that, just basic things like that, and expand our participating stakeholders. Another thing we talked about was priorities, what we think we should start working on. The first one is the scope of what we mean when we say implementing ICD 11. So what are the use case scenarios we're looking at? Are we looking at going beyond HIPAA, or are we just looking at satisfying those requirements? Are there clinical documentation use cases? Certainly we know for behavioral and mental health domain, yes. Social and community health. How will ICD 11 impact quality measures and quality reporting? And also, we thought it would be important to start communicating patient safety benefits. So organizations, you've seen the list. Mostly this is, all of these are repeats, I believe. What we did is we actually listed out areas where we thought the different organizations could contribute to some of the research. Like, for example, mapping studies, maybe NLM, the code system stewards, and standards organizations. Quality and safety would be AHRQ and AHIP potentially. So you can read that. But I'm going to go to the next slide, so you won't have too much time. So we thought how we should, about coordinating and sustaining this community. We definitely thought that it needed to be at the federal level, and we thought it should be some area of health and human services. We did not put NLM on the list, but we put down ONC, CMS, CDC, HRQ. Oh, and then this is just the question slide.
Safe.
That's true.
This is Jimmy Chang from Duke. I'm speaking on behalf of Group D. We have everything on one slide, but because it's so densely packed, I'm going to try to be a little interpretive for you. We did have some framing thoughts. One actually just popped into my mind as I was planning on coming up here, and that is a book I recently completed reading called How Big Things Get Done. I would actually recommend everybody in this room read that book. It was published last year, but authors are Brent Flyberg and Dan Gardner. And the reason this popped into my mind is because there was a term that had circulated on our table that this is kind of akin to a Manhattan Project. This is not a small project that we are tackling here, where a group of folks that raise their hand and volunteer can actually pull this off. This really is a big project. So instead of starting off with asking the question who, we actually asked the question what? What's really the starting point? What is this entity, if you will, trying to do? So the entity has multiple different responsibilities, obviously needs to decide, define what the program is going to be, that's going to result in the rollout of ICD 11. that the entity needs to be in the business of building relationships, of coordinating, of, again, developing the program. It needs to be inclusive of representation. It needs to include both federal as well as non-government stakeholders to accomplish execution. And then that took us to the question of, well, who should be doing this? So the starting point for us was we just put a stake in the ground. We said the secretary needs to appoint or designate a responsible individual or / entity to be executing these goals. Perhaps a national center needs to be established. One idea that was floated was that it would roll up to the White House Office of Domestic Policy Council. Another was to house it in the National Academy of Engineering, Science, and Medicine. So we're trying to think a little bit outside the box. But the point of this is that there really did need to be a responsible entity, a responsible party. That party also needed to be authorized to manage funding opportunities for granting purposes. And we did raise the question, like was seen with several others, to identify, if you will, how other countries have done this. Are there organizations that must be included for the longitudinal success? The answer is very similar to the list that you've already seen. So we did include the World Health Organization, but also obviously federal agencies, professional or clinical societies. One I've not seen so far, but are the coding societies. There's the American Academy of Coding Professionals. They need to be represented as well, and informatics and standards organizations. What is needed in the U.S. that is fundamentally different from other countries? We didn't really specify what's needed, but what we would need to account for. And those things everybody in this room is aware of: the fragmentation of healthcare delivery, our myriad of ways of accomplishing healthcare funding, even down to the details like DRGs, how value-based care rolls up into this, how prospective payment systems, and multiple payer environment. Another thing that needs to be accounted for was our emphasis on diversity, social determinants of health, and sexual and gender identity. We thought those were things that were important issues in the United States in particular, that may or may not having studied it in detail, may or may not have raised to a high level within the ICD 11 framework. And then even things like language variation and anachronisms or other weirdisms of American English need to be accounted for. So what would be the essential steps? We really want a Czarina appointed. All right, so there needs to be an assignment of a Czarina, enabling legislation and or regulation, some way to figure out funding, identify the responsible entity, and then start developing the structures. So thank you very much.
We had a mandate about
Before we go to the, we have about 5 minutes for any burning questions right now.
I noticed one of our work group members, Andy Wiesenthal, had put some comments in the chat. Andy, the folks in the room couldn't see your chat comments. Are you interested in sharing either one?
Well, we spend a lot. I would share two. The first one was, as it was compared to the Manhattan Project, I also hope we won't blow up the world. But in that regard, we've talked with a bias all day and really for months, and that is U.S. healthcare is complicated, and we have to figure out how to make this set of tools, ICD-11, fit into our complicated context. And I would say that, well, it's not our responsibility to accomplish what I'm about to suggest. It's our responsibility to suggest it. And that is, can the implementation of this really wonderful set of tools that has been developed for use around the world be a lever for HHS and CMS to help reduce the complexity in the US healthcare system rather than the reverse? So I realize that may be a Pollyannish idea, but without suggesting it, it will never happen. And I think if we can point out to CMS if they can do burden reduction for the delivery system related to funds flows, related to billing, related to their needs for data, that maybe this is a way to make our system a little bit less nuts. Just a thought.
Okay, thank you, Andy. Any other comments or questions before we go to the public comment period?
So I guess I would ask the committee members like you, Jamie, and you, is this what you want to hear? Like what you've been thinking about this for months. Like so is you want it this day?
If you ask me personally, the answer is yes. And, you know, I think in the work to come really is how do we raise up these things and pick, you know, and focus on, you know, kind of the most effective is a task. But I think hearing diversity of thought, I'm an academic, so I always love diversity of thought. And then, you know, the hard part after that is trying to, you know, really decide. But no, I thought it was really good what we've heard so far.
But I think there's diversity of thought, but real consistency of themes.
Yeah.
There's a beautiful paradox, right? Diversity of thought and a consistency of themes. And I kind of I like that. Thank you. Yeah. Well, if there is going to be a little bit more time, let's pause for public comments. If you could put up the instructions. Does anyone in the room like to make a public comment? You can come stand here where there's a speaker or a microphone overhead. Anyone in the room, please come forward and share your name and your organization. And you have up to 3 minutes. You just stand about right there and you're good. Yep.
Hi, Dr. Nelson Messina, and I'm here representing the profession of acupuncture. In ICD 11, Chapter 26, there is a section for traditional medicine codes for the first time. We've heard a lot today, and I'm incredibly thankful for the collective experience in this room and all of the diversity of thought. We've heard a lot about what the challenges would be implementing, and I want to speak more to what the incredible success could be for my profession specifically. I serve on our National Trade Association, work with the largest provider of malpractice insurance for acupuncturists and allied health, and I'm a practitioner myself. And this would mean recognition. It would mean enhanced communication, particularly between different provider types, to be able to understand the medicine a little bit better and how patient care is being rolled out. And it would also really create an opportunity for patients to have better access as this continues into the future. So the last speaker on the Zoom, I don't think that's particularly Pollyannish. I think it could really happen, particularly for my profession, if there was a better understanding, better access based on, oh, hey, this is a legitimate medicine. I mean, we have over 100 VAs utilizing acupuncture at this point. There's incredible patient demand for it. Medicare has recognized acupuncture, but the holdup is often with insurance. And we can't ignore the fact that that's part of our healthcare delivery system. That is the patient experience. That's the provider frustration that we also have at times. And this really is a way to help mend some of that communication, to start to be able to better educate insurance companies, again, different provider types and patients as well, so they can have better access. So thank you all so much for being here and allowing me to do some public comment.
Great, thank you. Anyone else in the room like to make a public comment? Okay, so online, we have one hand up, June Bronert. And we are opening up your line now. And please say your name and your organization and title, please.
Hi, this is June Bronert. Can you hear me okay?
We can. Thank you, June.
Hi, June Bronert, Vice President, Global Clinical Services with Intelligent Medical Objects. And the comment is appreciate the NCVHS's leadership to start the conversations and all the efforts to date, which really does highlight the complexities of ICD-11. And it shines a light on all the various data uses throughout the healthcare ecosystem. And the more information and resources the industry has access to, such as the underlying ontology being accessible to the public and not limited to the WHO's API during the public comment period and beyond, will continue to support the various conversations that need to occur for the advancement of ICD-11. Thank you.
Thank you. So again, you can raise your hand. For those of you who are on Zoom on the public side, let us know if you'd like an open line. I'll wait 30 seconds. And if you do have something you want to share but don't have it ready today, you can always send us comment at ncvhsmail@cdc.gov. Okay, well, with that, I think we are done with public comment, so we can come back to our agenda. One just popped up. Catherine Isabel. You just got in under the wire, Catherine.
Yes, thank you. I was having difficulty finding the raise hand feature on my mobile device here. But I did want to thank the group for your fantastic work.
Catherine,
Yes.
Where are you with?
I'm sorry. I'm with Lexicode. I'm a coding educator, but I'm just speaking as a member of the public right now.
Thank you.
I did want to thank everyone for their fantastic work. This is just really fascinating to sit here and watch this all unfold. We are looking forward to ICD-11. I think most of us are anyway, but one thing that I think is that the medical community should really play the major leadership role here, because nobody knows medicine like the practitioners know it. And the bottom line is the coding must reflect the documentation that the provider has given us. And so having coding language to match the clinical language much better than what we have right now would just be wonderful. And it would, it would get rid of a lot of ambiguity and a lot of those things. So that's just my thoughts. But thank you again.
Thank you. Andy, did you want to chime in so that the folks in the room can hear your thought?
Well, I would just say, I would rather slightly alter the comment that was just made and say that there should be an absolutely ironclad link between documentation and coding. So coding shouldn't reflect documentation. Documentation should drive the specific code in an automated way so that we can have very reliable and repeatable data and analysis. That's crucial.
Okay, it does seem like public comment is over, so we will turn it back over to our co-chair.
Okay. We're in the home stretch for the day today. Thank you very much. Thank you all for the robust discussion and courthouse that you all have. So I'm gonna start by recapping the morning a little bit, and then we're gonna go in recapping the afternoon discussion. So I'm going to create a slightly new script. I was going to say a script, but I'm creating a new script for this. So Patrick and I will both recap some of the morning discussions as we've heard it. Following that, what I would like to do is I'd like to turn to the facilitators of each breakout. And I'd like to ask each facilitator to identify a top priority. I think every breakout room identified a large number of priorities, but from your breakout discussion, can each facilitator identify a single top priority next step?
that we should take. So that's I'm asking the question now, then for you to think about, and we'll come back and harvest those responses from facilitators in a few minutes. So just a few, yes.
I'm a facilitator.
Yes.
And I want, is it from a time
after
our group or the whole?
From your group.
Our group.
From your group, the afternoon discussion, can you identify a single top priority next step? That's the question.
Okay, thank you.
All right. So before we get to that, I'm going to make a few introductory comments from my notes about the morning. And Patrick has, more fancy than I have, created a slide that summarizes a lot of the morning discussions and observations. So I think, my notes I have for the morning discussion. So obviously NCVHS is seeking information to support policy recommendations on ICD 11. And we're here to gather the collective wisdom, agreements and disagreements among, a wide variety of stakeholders, really representing hopefully all the different potential interests in the adoption and implementation of ICD 11. One of the things that we heard, I think, repeatedly is that post-coordination absolutely is required. But in many cases, it can be packaged in predetermined sets to reduce the impact both on clinician users and coders, as well as on the system's implementations. I heard a lot of commonality in many of the discussions about needing evidence of benefits and understanding to whom and where those benefits would accrue. That is absolutely something that is a gap in our current understanding. I heard repeatedly a need for centrally coordinated governance, including both government and private sector entities. I also heard about the need to accommodate a very wide variety of use case scenarios. So not just what we use 10CM for, but beyond that into, potentially many different areas. And that's one of the things that I think we heard this afternoon is the need to determine which scope exactly are we talking about. I also heard questions about, frankly, how much of 10CM is needed. Because if, as it was said a couple of times, if we're simply replacing 10CM with exactly the same thing in 11, then why do it, right? And I think we need more information about what new or additional information is in ICD 11 that leads to the potentially valuable uses of 11 in order to have the scope of implementation and use be broader than 10CM in our implementation. And then, again, back to just general questions about the benefits and costs driving a need for regulation, as well as potentially incentives through both carrots and sticks to get to a full national adoption and implementation. And to do all of this, obviously, you need funding sources. And that was something that it was, came out very strongly both this morning and this afternoon. So with that, I think you have Patrick's slide summarizing the morning more elegantly than I just did. And I'll ask you to go through that.
That was awesome. So I was tapped to draw some themes from the 7 groups from the morning's discussion, and that allowed me to get out of reporting out from any individual group. So I said, okay, I'll do that. So next slide. So I did review all the slides that all 7 groups presented, but of course I wasn't in all 7 groups. So I must have missed some really important things that were in the discussion. But I heard 3 thematic areas for research. If we're going to have a national research agenda related to ICD 11 over the next several years, I heard 3 major themes. The first theme was about the content and mapping. So building on Kim Ma's excellent work, expanding these comparisons with ICD-10-CM and with SNOMED CT. There were some interesting comments or debate about whether there will be a seamless integration between SNOMED and ICD-11, or whether it's a winner take all, that ICD-11 will win and SNOMED will die, or vice versa. But this research needs to really probe gaps and weaknesses, and to distinguish what we might call pseudo gaps, things we want to abandon, we don't want anymore from ICD-10-CM, from the true gaps that need to be addressed, and a lot of concern about social needs, for example, being one of those gap areas. We need to explore and test alternative linearization approaches and associated coding rules, really figure out the message was we're not going to do a clinical modification in the traditional way, but we have to explore what are the practical approaches to linearization. Again, Kima has laid out some of the alternatives. I know other groups have worked on this as well. Do we use the MMS as the foundation? Do we go back to all the URIs in the foundation? Do we add extension codes? Do we add STEM codes? And what are the governance issues related to those linearization alternatives? So that's the first theme. The second big theme is around tooling. Developing, testing the tools that we're going to need to make this work, especially for post-coordination. Front-end tools for user interfaces to support correct code assignment, but particularly at the back end, using structured fields in the EHR, using free text to build codes behind the scenes so that we can minimize the burden on healthcare providers. So we need research to evaluate the usability, the accuracy of these toolings, and the associated training needs. Cognizant of heterogeneous needs, particularly, for example, rural hospitals, small practices, solo practices, and so forth. The third major theme is around value and impact. Really understanding, as Jamie said also, who's going to bear the burden, who's going to see the benefits. We need to conduct demonstrations and pilots. Some of those could be retrospective, using data that already exists in electronic health records. Some will be prospective to really evaluate toolings and see how it works prospectively. We need to estimate cost and benefits for different stakeholders. How do we mitigate those costs? Do we need financial incentives? And then assess workforce implications, educational resources, productivity, burnout. So 3 major thematic areas for research. And I hope this is helpful as we go forward to, and again, I apologize if I left out anything really important. Feel free to chime in and we'll get it added in.
You want to do that now while that's up? Is there anything?
I was going to do that after we hear from the facilitators. Okay, now I would like to go through the groups. We've gone in reverse order thus far, so but this time we'll take it from the top. So Group A, what was your top priority takeaway from the afternoon?
Group A, I think it was governance with funding.
Governance with.
That seems to be.
All right.
There's a lot that's going on. We need a strong governance organization, whatever that may be, to really take a hold of this and see that things get done in a timely manner. Nothing falls through the cracks.
Excellent. Thank you. Okay, Group B.
The disclaimer will be, if there's disagreement, I apologize in advance. Group B, this needs to be an evidence-driven process, in which even goes to the RFI. I mean, asking people's opinions about why they think it's a bad idea, if they can't back it up with anything more than their opinion, I think is a fool's errand. So this needs to be an evidence-driven process. Governance is going to be a major issue. I'm a big fan of private-public collaboration, but nothing's going to happen without funding. And I think those are the takeaways.
Okay. Another vote for governance fund. Okay, Group C.
I have a list here, but mainly
You have a list of
it was,
top
it was a
number
list.
one items?
It's on how we can continue the collaboration. So I really think we should continue the collaboration and use communication tools on the NCVHS website to engage this group as well as others, so we can discuss and keep communicating together. One, we should be communicating very, very strongly the benefits of ICD-11. Expand on Kinwa's excellent research. Talk about those codes that are truly needed, the frequency, the utilization, the common codes, the rare codes, and then incentives. What will really get the buy-in of our stakeholders and show the benefits there, and then develop the use cases and carve out moving forward WHO. So that's all the communication part. So that's stuff we wouldn't have achieved.
All right. Group D.
Okay, so we did a little polling over here. So the notion of having it organized, coordinated, this is our idea, by a neutral entity, which puts into place a process that is collaborative and also has the authority to actually move ahead.
Thank you very much. Okay, and let's turn to Zoom, and we'll have Group E.
All right, Group E, that would be,
That me?
yes.
Okay, we took Susan Fenton's urging to heart. And while we agreed about a broader governance and funding, we looked very short-term, very practical, and said we've got to leverage the ability of NCVHS to convene, to recommend, and its credibility, and put our shoulders towards support for this committee. Our recommendation, you'll recall, was to expand it so that it could work in parallel on 4 fronts through subcommittees. And we understood that in order for that to happen, we needed, HHS would need, or CDC would need to fund additional staff support for the committee, because NCVHS has other things on its plate as well as this. But from a short-term practical, keep the ball rolling, it doesn't seem to us that setting up a new entity is not a short-term issue, and we need to build the case for it and build the momentum for it. And this group could be the foundation for doing so.
Excellent. Thank you so much. Okay, let's go to Group F. Who's the facilitator of F?
Yeah, so I don't have a chance to talk with our online group. So I would say it's first the leadership, really have leadership to solve the governance issue and the funding issue. This governance and the funding issue keep come up in our discussion. And the second one is the private and the public partnership. So this has to be inclusive, and also the transparency and the communication education roll into this partnership. That's my summary.
Thank you very much. Okay, and last but very definitely not least, we'll go to Group G, which is Maddie Hugh.
Hi, yes. In addition to everything that's already been mentioned, the one item that we had was also just designating the lead federal agency and establishing the timeline, the roadmap to pursue the efforts. But we had also discussed everything that's already been mentioned.
Thank you very much. So I think as a first next step in this discussion, I want to ask for any questions, clarifications, additions, or discussion on both the summary warning and what we just heard as top priorities. So in the room or online, questions? Vicki.
One of the things that I'm concerned about is that I'm trying to understand where research comes in. And let me be very clear, I'm not talking about research on ICD-11 itself, but how we embed research into ICD-11 on an ongoing basis that allows us to do what the United States is charged with. CDC does prevention. We are responsible for using data to really think about how to prevent disease and disorders. What we have that we focused on is the disease and disorders itself. So I'm a little concerned that some of the research that's needed has to be elevated in this discussion. So I'm going to do one of my biases, which is I'm a psychologist. So for example, if we're doing some of the mental health, behavioral, neurologic disorders, it's not always just we need to have the diagnosis. We need something else. And there are many other areas where, and I have said on Healthy People, I can't remember which ones, 2010, 2020, those kinds of things. And we always end up with not having the data that we need. So I don't want us to not attend to that question of how do we pay for, build in, incentivize the collection of the research data that we need using ICD-11 that allows us to fulfill our prevention mission.
So I really appreciate that. I have to say, as a recovering research investigator myself, I certainly appreciate the need for the data. And we haven't really here today thus far discussed the need for data for not just the clinical research, the social research, the population health research, the equity and other policy research that's really needed to fulfill those missions that you talked about. And it's so important that now that's captured for today. And so thank you. Jeffrey.
So I think I've heard lots of different areas of discussion going on today and a lot of good ideas, but I'm not hearing a clear message of what our expectations are. And your majority audience is going to be the clinicians in the hospitals. And if they don't understand the principal purpose and all they hear is research and public health and reimbursement, then you're going to have an impossible time selling your message and trying to move forward without a lot of resistance. So I think you have to be very clear that this is a replacement or the upgrade for a classification system for medical diagnosing that can be used in these other research areas. But if you start talking about research first and reimbursement, you're going to have an impossible time. And I also think that when we're talking about the organizations to be involved, again, the medical community is comfortable with NCVHS CDC. Okay, they know this is all for statistics and epidemiologic. And if you start saying somebody else is going to be your principal contact, or you're not going to be including them in the private government partnership, again, you're going to have a hard sell. So I think you need to take more of this into consideration. What is your main message and how you're going to stretch it out? And I would be careful about bringing payers to the table. You don't want this to be like the RUC. And again, if clinicians in hospitals are seeing payers at the table making determinations on coding, there's going to be pushback because now it's becoming a reimbursement coding system instead of a tracking system.
Thank you. Appreciate that. Any other immediate comments, either online or in the room? Because if not, what I'd like to do is to elicit some discussion on some of our next steps. So we will have certainly a transcript and a meeting summary will be prepared by staff for this meeting. So we'll have the transcript and all the documentation. Recording of both the room, all the discussion breakouts. all the whispering at your tables actually has been recorded. Cut out for lunch. But, so we'll have all that information in a meeting summary that's, really a transcription of the meeting. But then also the work group will reconvene after this meeting to draw conclusions, insights, observations, and to develop potentially some draft recommendations to forward to the full NCVHS committee. And so I think in terms of thinking about that report, the analysis of everything that you've heard here today and experienced here, in terms of that analysis and reporting on using this to drive a set of initial recommendations, needs to be in the report. So what are some of the key things? It may be just the themes that that we've sort of regurgitated and documented here, but maybe there's something else. Maybe there are other items that you feel are critically important to be included in the report from this expert review. So I'd like to get input on what needs to be in the report.
And we're taking notes.
Supposed to see. I just echo adding on to this gentleman's comment, where some parties should be excluded or the message should be one central message. I think we have to recognize we're past the basic healthcare delivery system with physician patients, right? And we moved on to research. There's so many pieces within the healthcare sector that crosses the whole healthcare data ecosystem, right? And so we need to make sure we include in that work those key stakeholders and really think clearly what is the value to them. It's not going to be the same core. It's going to be the overarching concept, but then everybody's going to have a subhead. Vicky's going to have a different subhead than the payers will, than the providers will, than the coders will, than the nurses would. And so we need to drill to that level so that we can actually be compelling to get people to participate in that section that they're comfortable in, right? More participation, the more we can tackle. That's what we should work.
Thank you. Becky.
One of the things that I think would be interesting, and I don't know what our timeline is we have people here who represent some of those stakeholders. It would be great if the slides that we did today got sent to them and asked them to have a discussion in their organization and then send us back some comments.
And the comment then would feed into the report to be considered by the work group. So, I think that's exactly right. I do think that we agreed all the materials presented here today will be distributed out to everyone here, and all the public slides will be made on the website.
So they actually all the slides that we had, including the report outs from last Thursday, are now posted on the August 3rd meeting page. They're all there on the right side.
So we'll have the materials out, but I think what you're suggesting, Vicki, is essentially a to-do item or an assignment for everyone in the room and online in the expert roundtable today to take those materials back to your audiences, to your organizations, to your stakeholders, and use those to get input back to the work group to provide more input for the report that will be worked on over the next roughly 2 to 3 months.
I would only want it to be today's stuff. I don't want us to go back to the 27th.
Just
so you want us to package up the notes from the morning breakout and the notes from the afternoon breakout.
Yes.
We'll send them to everybody here, and I've almost got all of them. And we can probably do that relatively the next day. Yep.
So those materials are available. Okay, I have Denise and then Jeffrey.
And to follow on that, it's a big ask to take to an organization all the content slides. If as we consolidate a 1 or 2 page issue brief or something so that it's more like.
I would say, so Denise, thank you for that, because you're right, that if all the materials is a big ask and who's going to review that, I think, so if it's really most appropriate for you to bring a 1-page summary or an issue summary or issue brief based on this back to your organization, stakeholders, then that's appropriate. In other cases, there might be an appetite for reviewing.
Well, yeah, you can have both, but I just think it's going to get disseminated if it's easier to digest for some stakeholders.
Jeffrey, and then Patrick, and do we have any online? No online. All right, Jeffrey.
So, I mean, this comes partly from working with WHO for as long as I have support what.
Sorry, can you stop the?
This comes partly from working with WHO for as long as I have, and I want to support what Jeff Windsor said in this regard. That there's I think it's very. It's really important that the governance of this be seen as clear and free of conflict. And so it's one thing for everybody to say, oh, I don't have any personal conflict with regard to the topic of today's meeting. And I believe people when they say that. However, I mean, inherently, a payer has a conflict of interest if they're at this table, and that's what it looks like. So I'm not in support personally of a public-private partnership as a way of operating. I think we should be a government thing that's centered in the public interest, that's centered in public health, and that you have meetings to consult with the payer community, or meetings to consult with vendors, as much as you like, but that the control and decision making needs to be invested in a group of people that really is seen as having integrity and the public interest in mind. The product of the healthcare system are healthcare interactions, and all this infrastructure is built around it. So I agree.
And Jeffrey, if there's no budget, then what do you do?
Well, then you maybe think about not doing it. Frankly, I think it's going to cost money. I don't see how you could do this without money.
Okay, thank you. Patrick.
Yeah, just tying this point to the idea of having another RFI. So I'm not sure if the timing will work out, because by the time you get approval to put something in the Federal Register and provide adequate response time, this report may have closed. So we'll have to work out the details of that timing. But I'm wondering, are there thoughts about in the next RFI, we'd like to engage more stakeholders, to hear more voices, but maybe more sharply focused questions, maybe a new set of questions that really drills more into some of the key decision points. So just curious about you and others.
A suggestion that as a work group, as we reconvene after this, we can take what we've heard here today and use that to refocus the questions for the revised RFI. We have heard a couple times today suggestions for a 90-day comment period, which I think is entirely possible. So we'll work with the federal staff to see maybe 60 or 90 days, but something along those lines should easily be possible.
And are you up for a homework assignment, work group members, to actually come up with your top 3 to 5 questions, send them my way, so that when we get together, we can actually, that's what we will talk about?
I think that's a good idea. So that is a homework assignment for the work group members to consider, what would be the top priority questions for the revised RFI.
I would call it a follow-up RFI.
Follow-up, yes. That's better.
Sort of whittling, we're focusing.
That's true. So a little bit more focused. Vicky.
I want to hear from the first homework assignment, which is people going out to their groups and coming back. Otherwise, we're who we are in here, but we're trying to make sure that we're a little broader. So if we're going to send a follow-up RFI, we want to make sure we broaden it to hear from those other groups we didn't hear from as much. And here we're kind of healthcare oriented. Not that that's bad.
Right. So I think, we had the suggestion of the homework assignment of everyone here to take the materials from today, either in whole or in summary form, back to your stakeholders to get input and send it back to the work group. What is the appropriate turnaround time or timeline for expecting those responses back to the working group? 1 month?
At least 1 month, maybe 6 weeks.
Okay. How about mid-September?
That would be September 15th.
So September 15th? Okay, so then we're just, refining the homework the first homework assignment. So this is a homework assignment for everyone here, both the work group members, including committee members, and the invited experts, to take materials or a summary from this back to your relevant organizations or stakeholders as you determine, and see what information we should get back to help us formulate the report on this from today. That will also inform the refocused or follow-up RFI in terms of what the RFI questions on. So that will inform that.
And then homework item B, that's A. B more specifically is if we're going to get this RFI out sometime in September and have a 90-day period, so we'll start off the new year, right, with some information for people. Work on those in the next 2 weeks if you would, and we need to get a full work group meeting scheduled, which we will do.
Okay. So we have a couple of homework assignments. Any questions on those assignments? Okay, I think we've done a few minutes early here, actually. I want to say how much I appreciate, just all the, tremendous effort everyone has put into coming together for this event. All the thoughtful input, both in the pre-work, the pre-meeting, the breakouts. For those of you who were able to travel here or to spend the day with us online, I really appreciate so much your time, effort, and attention to this. We've gotten fabulous input, because I think we've heard around the room on the question of whether the objectives for the day were met, resoundingly yes. This is, I would say this has been a great success in terms of getting the broad kind of stakeholder input that we need to move forward on questions that inform the committee making ultimately its policy recommendations to the Secretary of HHS on the adoption and implementation of ICD-11 for all purposes. And with that, I think that we're adjourned. 15 minutes early. Thank you.